Now hand over to the chairpersons.
Good evening, everybody. In post-lunch session, we are going to discuss about some important topics. Now, the topic is juvenile rheumatoid arthritis, and it will be delivered by Professor Tridip Kumar Das. I request Tridip Kumar Das to proceed.
Hello. Good afternoon, respected chairperson, respected teachers, my dear colleagues and my dear friends. So I am very much thankful to the organizing committee for allowing me and requesting me to come over in this prestigious dais to present the paper over here. So today I've been asked to talk about juvenile idiopathic arthritis, when and how to suspect and manage. So when and how to suspect a case of juvenile idiopathic arthritis. So GI has to be suspected in any children less than 16 years of age who has been suffering from arthritis, especially for more than 6 weeks, when all other causes of chronic arthritis has been excluded. So it is present as a chronic joint swelling, pain with functional limitation for at least 6 weeks of unknown cause that starts before the age of 16 years. So different classification has been put forward at different times. The first classification which was being put forward was by ACR in the year 1977 as juvenile rheumatoid arthritis. So they have classified as 3 varieties: systemic, polyarticular, and polyarticular. In the very next year, Euler has reclassified it as juvenile chronic arthritis, and they've added 3 more types of juvenile rheumatoid arthritis, juvenile psoriatic arthritis, and juvenile ankylosing spondylitis. So till next 2 decades, this was the classification which was in practice. So after 2 decades, it was the International League for Association of Rheumatology who have reclassified this as juvenile idiopathic arthritis. That is, there is no cause of this particular arthritis. So they have made these types much more specific in order to get some more benefit in the treatment module. Systemic is there. Polyarticular, they have reclassified as rheumatoid factor positive and rheumatoid factor negative. Polyarticular, persistent, extended, psoriatic arthritis, anticyst-related arthritis, and undifferentiated arthritis. So this is the variety right now. So what is the frequency of involvement? Basically, it is the oligoarthritis, which is one of the most commonest form of GI in every cases. So if it is followed by RF negative polyarthritis and anticyst-related arthritis. Now, if you talk about the gender, definitely, you can see in most of the cases, it is a female preponderance, you can see, except in anticyst-related arthritis and in systemic arthritis, where in anticyst-related arthritis, it is the male preponderance, and in systemic arthritis, both the male and the female are equally involved. If you talk about the age in oligoarthritis, it is the age of onset is less than 5 years of age, and the RF negative polyarthritis as well as psoriatic arthritis, they have a bimodal distribution, means one may be involved at a very early age and the other may be involved at a later age, later childhood. And if you talk about RF positive polyarthritis, then it basically occurs in late childhood. Similarly, anticyst-related arthritis, which also occurs in the later childhood. So these are the presentation I'm going to discuss later on. So what is the epidemiology? Basically, you can see that approximately 3 million children and young adults are estimated to be suffering from GIA. Just GIA is one of the most commonest rheumatological disorder present in children. So some specific types are basically present in some specific geographical location. As for example, rheumatoid negative polyarthritis is basically present in Northern America or America, whereas oligoarthritis is much more common in a patient with what you call in European countries, whereas psoriatic as well as anthracite-related arthritis are much more common in Asian subcontinent. So if we talk about the pathogenesis, we all know that it is an idiopathic cause, so the cause is not very pronounced, it's not very, but still some pathogenesis has been put forward in order to get a very clear picture how to approach this patient in the management. So all forms of GIA are basically, except systemic GIA, are disorders of the adaptive immunity, where the T lymphocytes play a very important role in the pathogenesis. Whereas in a systemic GIA, it is the innate immunity where polymorphs, what we call monocytes and macrophages play a very important role in the pathogenesis. So it is a balance between the pro-inflammatory and the inflammatory cytokines, which basically determines the degree of joint damage. So this is the what we call pathogenesis, where you can see in case of oligo polyarticular, it is the interleukins which play a major role in the inflammation, whereas in systemic GIA, it is the macrophages which cause a systemic damage in every part of the body. So if we talk about individually clinical presentation, so oligoarthritis is one of the most commonest presentation of all GIA. So it can be reclassified as persistent GIA, as extended GIA. Persistent GIA means at the time of presentation, for the first 6 months, they are only less than or equal to joint involvement of 4. But if after the first 6 months, if more than 4 joints are getting involved, then definitely it may go into extended variety. It will behave much more like a polyarthritis. So persistent GIA is the mildest form of GIA. Female are affected more than the male. It basically affects the larger joints, and one of the most commonest complications of oligoarthritis is persistent oligoarthritis is basically uveitis. Those patients who have ANA positive are more vulnerable to getting uveitis. So it is very rare for this oligoarthritis disease to have permanent joint damage unless and until you're not going to go for any treatment. So extended, we all know that once the patient is not going into treatment and there may be larger bone involvement, both the small and the large joint gets involved, more than 4 joints are getting involved. So this sort of arthritis will, in the future, will behave like a rheumatoid arthritis. So children may be very much well despite amputating with a limb. In case of asymmetrical arthritis, chronic inflammation is there. So there can be some sort of an overgrowth of the particular limb and there will be subsequent leg length discrepancy. So the second most commonest presentation of GIA is the polyarticular or the polyarthritis GIA, where the time of onset more than 5 joints are getting involved. These are also 2 varieties. One is the RF positive polyarthritis and the second one is the RF negative polyarthritis. So if you talk about RF positive polyarthritis, this condition basically affects the older children, and there is a high preponderance for female, as we all know. And it affects both the larger as well as the small joints. It is symmetrical onset, and it behaves like an adult onset rheumatoid arthritis. So the affected child may also present with many other features of rheumatoid nodules, anemia. There will be also constitutional symptoms like significant fatigue, poor appetite, low-grade fever, and general well-being will be also there. So the onset of, if you talk about the RF negative polyarthritis, the onset is a bimodal distribution. One, the child will be very much young. They may present in a very younger age of less than 5 years. On the other may be presenting at a later age of around 9 to 11 years. So girls are in fact are more affected than the boys in this case also. And usually starts in many joints at the same time. So these are not symmetrical in onset. These are basically asymmetrical. And this type of GIA basically may run into the adulthood. So there are features which may poor prognostic features for polyarticular GIA. Like if the patient is having RA positive antibodies, anti-CCP antibodies positive, if there's involvement in the hip, cervical spine arthritis, and erosion of joint space, if there's other features like early hand involvement, etc. So these features basically shows the poor prognostic features of polyarticular GIA. If you talk about the systemic GIA basically presents more of a extra-articular manifestation. They present with fever, transient salmon pink rashes. There will be hepatosplenomegaly, lymphadenopathy, and anemia. There can be also presentation of serositis in the form of pleuritis, pericarditis, peritonitis, etc. So these forms basically present 10 to 20% of this GIA. It involves both the larger and the small joints. So the diagnosis of systemic GI can be quite challenging because both the fever as well as the rashes are transient. It comes and goes. The fever may be as high as 39 degrees Celsius. It may be sometimes coming down to around 37 degrees Celsius. Similarly, the rashes which are present over in the extremities as well as the trunk, which are pink macular rashes, these are also transient. This comes and goes. So sometimes it can be quite challenging. So their diagnostic criteria for GI are any fever patient of unknown origin having persistent for 3 consecutive days and recurring for at least 2 weeks, as well as 2 major criteria and 1 minor criteria. So major criteria are evanescent or transient erythematous rash and arthritis, and the minor criteria are lymphadenopathy, serositis, arthralgia, and leukocytosis. So any 2 major criteria or 1 major or 2 minor criteria, the patient may be suffering from what you call this systemic GI. One of the most dreaded and fatal complications of systemic GI is basically macrophage activating system. So over here, there will be features of hemophagocytosis leading to coagulopathy, there will be pancytopenia, there will be central nervous system involvement in the leading to maybe sometimes seizure, there can be encephalopathy. In fact, sometimes the patient may present also with coma. It is an immunological failure, and there will be massive hypercytokinemia. There can be cytokine storm with particularly overproduction of interleukins as well as interference as well as tumor factor alpha. So many triggering factors in a patient with systemic GI can cause this MAS. So like viral infection, medication, etc. can also cause this. This may be present in many other immunological diseases, but for reasons unclear, this is much more common. 80% of patients are basically suffering from systemic GI. So treatment of MA is a medical emergency and has to be carried out by expert. So it has to be treated immediately. So the diagnostic criteria, so any febrile patient who is suffering from, who has been diagnosed with a case of systemic GI, having ferritin level of more than 70 nanogram, and at least 2 of the following laboratory abnormalities: platelet of less than 1.8 lakhs, AST of more than 50, triglycerides of more than 160, and fibrinogen level of less than 360. So any of the 2 together with ferritin of more than 700 nanogram per liter in a case of systemic GI has been classified as macrophage activating system. So these are medical emergency. Active intervention has to be taken. So the first line of drugs is definitely in every case of inflammation is IV steroids. So I think IV steroids will far more better than the oral steroids. Cyclosporin A has got a very good role to play in this MS. But if for any reason you're not going to give these drugs, then definitely you can go for alternative therapy like intravenous immunoglobulin. You can go for plasma accents. Also the other molecules like biological agent, you can also use interleukin-1 inhibitor anakinra, which also plays a very good role in MS. Now coming to anticides-related, this anticides-related arthritis basically involves both the joints as well as the anticies. The age of onset is basically after 9 years. It lasts into adulthood. This is the case where male preponderance is much more than the female. Usually involves the larger joints. It's a few joints, in the legs, hips, and are affected. It also involves the ankles and heels. So any activities basically causes pain over in this area. So there can be maybe also evidence of dactylitis, tarsitis. ERA may also be associated with the diseases like IBD, acute anterior uveitis. HLA-B27 may be positive in most of the cases of ERA. So this is the diagnostic criteria. So arthritis with or without enthesitis plus any 2 of the following: parents or history of sacroiliac joint, positive HLA-B27, onset of arthritis is more than 6 years, acute anterior uveitis, or any history of ankylosing spondylitis, enthesitis-related arthritis, etc. So any of the 2 plus arthritis plus enthesitis will diagnose the case of enthesitis arthritis. So juvenile psoriatic arthritis, the features of GI appears to be quite heterogeneous. So these also have a bimodal distribution. One is a very early age of preschool, and the other may be late adulthood, late childhood. Over here, 80% of the patient of psoriatic arthritis basically present with oligoarthritis. And the most commonest joint involvement is the knee, followed by the ankle. So if you are not going to treat this patient, definitely from oligoarthritis, they are going to go into polyarthritis. So axial involvement is also very much common in this case. In contrast to the adult population of psoriatic arthritis, the juvenile psoriatic arthritis, there is less amount of bone erosion or destruction. So dactylitis can be seen. Various nail changes can be seen as seen in psoriasis, like there can be pitting nail, onycholysis, horizontal ridging and discoloration are detected. Chronic uveitis can be also found. Laboratory findings are not very remarkable. So the diagnostic criteria is arthritis plus minus psoriasis plus 2 of the following, like dactylitis, nail pitting and onycholysis, and family history of psoriasis. So this is a clinical, basically we should diagnose this GI as a clinically, but definitely we need to do a lot of investigation like CBC, X-ray, antibody, RF factor, complement factors, etc. So radiology has got a definite role to play in GIA. These are the findings of erosion. If we talk about the treatment part, when a patient of oligoarticular GIA, definitely we need to start with what you call NSAIDs. Then it will look for the disease activity. If the disease activity is, irrespective of the disease activity, if the poor prognostic signs are present, definitely we need to start with intra-articular injection as articular corticosteroid as well as continue with NSAIDs. If it is not improving, disease activity is what you call moderate to high, after 6 to 8 weeks, definitely go for methotrexate. Even if it is not controlled after 3 months, then definitely you can go for TNF alpha blocker. Similar in polyarthritis, we should start with non-steroidal anti-infective drugs plus the conventional DMARDs, except in case of sacroiliitis where we can use the, start with the biological DMARDs. So we can assess the disease activity. If it is not, if it is low, then definitely you can continue with intra-articular corticosteroid and optimization dose of conventional DMARDs. If the disease activity is high, then definitely you can add biological DMARDs, which is the preferred one. And if not, then you can change to alternate conventional DMARDs. You can see disease activity. If the disease activity is low, definitely you can use ISCS and optimization dose of conventional biological DMARDs. And if it is high, then definitely we can choose other biological DMARDs. Systemic, also we can look for whether there is active arthritis or systemic features or more. If there is active arthritis, then intra-articular injection, corticosteroid, as well as exon and NSAIDs. 1 month you should look for the disease activity. If it is moderate to high, definitely you can go for methotrexate. Otherwise, after 3 months, if it is responding well, okay. If it is not responding well, then definitely you can go for other biological agent like TNF alpha blocker, interleukin 6 blocker, tocilizumab, or IL blocker, anakinra. If the systemic features are more, definitely if there is a certain fever, then definitely we can go for systemic glucocorticoids. If not responding, then you can go for IL-6 blocker as well as interleukin 1 blocker. So these are, we can also use if TNF alpha blocker are not being helpful, then definitely you can go for anti-T cell or anti-B cell. Anti-T cell like abatacept as well as anti-B cell like rituximab. So these are the biological DMARDs you can use in GIA, different biological DMARDs. So many complications, one of the major complications is definitely MS and chronic anterior uveitis, atlanto subluxation if cervical spine is getting involved. So these are differential diagnoses, oligoarticular, they can be reactive arthritis, malignancy, polyarticular can be SLE, systemic, it can be inflammatory bowel disease, connective tissue disorder, SLE. So key takeaways are juvenile idiopathic arthritis is a heterogeneous group of disorder characterized by chronic joint inflammation and is the most common rheumatic disease of childhood. Early and aggressive management of GIA limits long-term morbidity associated with the disease. Biological disease-modifying anti-rheumatic drugs have revolutionized the treatment of GIA and have reduced morbidity but have not improved rates of long-term remission. The lack of improvement in long-term remission rates despite improvement in treatment strategies underscores the need for a better understanding of the pathogenesis of GIA, further tailored treatment approaches. Thank you so much.
Thank you, Dr. Reddy, for your nice presentation. Questioners will take up at the end of these 3 topics. We'll come to the next talk of this session. The next speaker is Dr. P.S. Karmakar. The topic he's going to speak on prevention of CKD, role of primary physicians. I'll invite Dr. P.S. Karmakar to please go ahead with his presentation. Dr. Karmakar is a professor, Department of Medicine, College of Medicine, and Sagar Datta Hospital, Kolkata. Dr. Karmakar, please go ahead with your presentation.
Respected chairpersons and the learned gathering present over here, I'm really thankful to all the team members of the organizing committee for giving me this chance of standing before such a learned gathering to have a talk on a very important topic, that is prevention of CKD and role of primary physicians. So I will take you on through this topic, that is prevention of CKD, what is the role of primary physicians, by briefly touching upon this following points: CKD, most important facts, CKD burden in globe and India, criteria for CKD, role of primary physicians in CKD is of great importance, how I will rationalize that thing. Monitoring of initial investigations, management guidelines, and take-home message. So now we know why the Titanic sank, because many important things was unknown that was under the deep into the sea, just like peak of the iceberg. And that is also, same thing is true when we discuss CKD. So because 9 out of 10 adults with CKD do not know that they have it, okay? And second is 1 in 2 people with very low kidney function, that means 50% are really unaware that they are having very low kidney function. And if you come to this block, that is 1/3 to 2/3 CKD patients do have dialysis unplanned without any vascular access. In the morning pre-lunch session, Professor A.K. Das was telling that CKD is increasing like anything. Now coming to the global burden of CKD. It is really a social calamity and economic catastrophe. And global estimated prevalence is 7 to 13%. And it has gone up 12th leading cause of death globally in 2017, up from 17th in 1990. What is the strategy of India? In the registry of India in 2011, when we had more than 100 crore of population, they registered only 65,000 around. So how low registry is there? That means it proves 9 out of 10 CKD patients do not know they are having CKD. Here lies the importance of role of primary physician to detect all these things very early. So when do we call a patient is having CKD? There are criteria according to KDIGO. So chronic kidney disease is diagnosed by one of the following persistent criteria over 90 days, if it persists more than 3 months. Abnormality of renal function on scan, renal structure on scan, albuminuria, that is albumin creatinine ratio ACR, more than 3 milligram per millimole, that means 30 milligram per gram of creatinine, same range in both sexes, or abnormal urinary active sediment in the form of blood and protein on urine deep test, and estimated globular filtration less than 60 milliliter per minute per 1.73 square meter of body surface. If one of that criteria persists for more than 3 months, we call patient is having CKD. Don't go by, try to change our mindset that only creatinine will rise, then we will call that patient is having some chronic renal disease. So we have to change that mindset to catch them young in the early part of the disease process. So CKD is present if all those findings more than 90 days, and up until 20 years ago, CKD was typically an issue of specialists and concerned severe renal damage, often leading to end-stage renal disease. And all this concept has changed. Our concept of CKD has expanded, and the role of primary care in minimizing renal morbidity has become a priority through guidance of PCP, that is primary care physician. Now coming to, do we care about CKD adequately after knowing all these things? Much, much less than adequate. We do not realize that CKD is hidden in the patients of diabetes mellitus, hypertension, albuminuria, and elderly people. The seeds of future CKD is lying in these three, that is DM, hypertension and albuminuria, and outflow obstruction and elderly people. So we have to care all these persons. And most doctors even screen less than 10% of their clinical patients for CKD in the early setting. So patients are referred very late to the nephrologist, especially after the CKD is irreversible. So I have already talked this hypertension type 2, diabetes mellitus, albuminuria, along with outflow obstruction is to be taken care of because they are symptomatic only, they have gone advanced. Majority of them are asymptomatic. That's why you do not put that much of care what is needed. So key observations, how did renal disease become a matter of primary care? From nephrologists, it is shifting to primary care physicians. Why? because firstly, I have already told that hypertension, diabetes, and albuminuria and outflow obstruction, these sort of patients where seeds of the CKD is, for future CKD is lying, so they usually come to primary care physician or family physicians or consultant physicians. And if you can control their renal dysfunction, further dysfunction, you will definitely control, in the other hand, that MACE, major adverse cardiac events. So both the things would be controlled side by side if you control all these three things. So when do we refer a person from primary care center to your nephrologist? Actually, up to the stage 2B, GFR is within 30 to 59 milliliter. From up to that level, stage 3B, that is 30 to 45 milliliter, up to that stage, the patient can be well taken care of primary care physician. Then the switchover comes. Then after a stage 3B, when the stage becomes stage 4 and stage 5, then the nephrologist comes in the front to take care of that kidney. So primary care physician's role is very, very important so far the early phase of the CKD is concerned, and so far its prevention or delaying in the process of CKD is concerned. Not the nephrologist, but the primary care physician's role is very, very important. Now coming to how much delay you can make. So if you really start the treatment at the level of the 50 milliliter, that is your third stage, that is in the stage 3 CKD, if you can control all those three things, hypertension, diabetes, and albuminuria, you can offer 2 years of ESRD-free life. So it's no joke. And if you can start your therapy at the second stage of CKD, that is at the around at the 75 milliliter of GFR, you can give that person 4 years of non-ESRD life in his lifespan. So he will not have to think at least that 4 years that I am to go for kidney transplantation. So such is the importance so far that treatment of primary care physician is concerned to delay the process of CKD. So usually diagnosis of CKD picked up incidentally even as of today in modern medicine. And abnormal GFR, if you see, and abnormal urine ACR, all these things are to be tested at frequent intervals. And what would be that interval? GFR and albuminuria in a patient of diabetes, hypertension, will be definitely be taken care of within at least once a year. And more often in persons, it is twice or thrice if the patient really carries a high risk of progression. And you all know that CKD is also associated with anemia. And anemia is to be, that is hemoglobin percentage is to be definitely to be detected. GFR, if GFR more than 60 milliliter per minute, that will not cause kidney disease, kidney dysfunction associated anemia. At that time, you will go for hemoglobin when clinically indicated. But if the patient does show GFR in the level of stage 3, at least annually you should go for hemoglobin detection, and stage 4 you should go for twice a year. And serum calcium phosphate, PTH, parathyroid hormone, and alkaline phosphatase not from the very early morning, you will need to go for from stage through B. So far management is concerned. If risk factors are minimized, then progression is likely to be slow. The management of CKD includes prompt treatment of urinary outflow tract obstruction, not to use nephrotoxic drugs. BP target would be less than 140/90. Now the ISH, International Society of Hypertension, in 2020, they have made it further low. Our target should be less than 135 by less than 85 millimeter of mercury. But if patient does have albuminuria to the tune of 70 milliliter per millimole, then you have to make it further low, less than 130 by 80 millimeter mercury. HbA1c optimization, optimal BMI, and smoking cessation are all these very important therapy so far the delaying of the process or prevention of CKD is concerned. Now, what about low salt diet? I will take a few seconds about that. Calories, what should be the calorie consumption of that CKD patient? We all the time try to reduce it. That will definitely reduce the muscle mass. And we had a discussion yesterday that if muscle mass is reduced, creatinine automatically comes down. And you will think falsely that your treatment is giving benefit to the patient. No, that is not the issue. So calories should be 300 to 350 kilocalorie per 10 kgs of body weight. And sodium would be less than 65. That means it comes around 4 grams per day. If you don't take any salt in your any sort of food, you will definitely be taking 2 grams. So only 2 grams could be given with cooking and all these things per day. And the protein intake would be very careful about that, 0.6 to 0.8 gram per kg, even up to the stage of 5. Otherwise, muscle mass reduction will be rapid. So recommendation, what is the recommendation? Diet I have talked about. Then ACEI. To reduce the albuminuria, we have to use ACEI or ARB. But remember one thing, ACEI and ARB is a very good antihypertensive for protection of heart as well as protection of the kidney. But if the albumin creatine ratio more than 70 milligram per millimole, even in the absence of hypertension, you have to use ACEI or ARB, angiotensin receptor blocker, to reduce albuminuria, thereby reducing both MACE as well as chronic kidney disease. But if there is hypertension, you start putting patients on ACEI ARB from ACR to above 30 milligram per millimole. Now ACEI ARB, word of caution. What is word of caution? Never combine these two things. Never, if potassium is more than 5 millimole per liter, and electrolyte and kidney function test 2 weeks after initiation or dose increase. We usually don't go for repeating your kidney function test in the form of creatinine or potassium after 2 weeks of initiations of ACEI, after initiation of ACEI in the form of who are having chronic kidney disease. Why this is so much necessary? Because ACEI and ARB will definitely reduce your GFR to the tune of at best 25%, and thereby increase in creatinine content from the basal level goes up to 1/3. That could be acceptable. But if GFR is more than 25%, then you have to readjust the dose. You have to reduce the dose so that the GFR will not reduce more than 25% of the basal level. And one must molecule is atorvastatin, 10 to 20 milligram per day is recommended in all CKDs. So far, care of the kidney disease along with the above what I have already discussed. Care of the kidney disease as a whole could be divided into primary, secondary and tertiary. Primary, just I have talked about, to take care of the hemoglobin, to take care of your albuminuria, hypertension, diabetes, along with their healthy lifestyle profile. But secondary, that means when actually the metabolic abnormalities has set in the form of either anemia or the bone marrow disorders, mineral and bone disorders. And tertiary care means when the patient is in stage 5 and you have to plan for vascular access and RRT. So specialist referral, I have said that at the age of 2-3B, that is when the GFR is 30 to 45 milliliter per minute, you should ultimately switch over from primary care physician to nephrologist. Definitely, it's a dictum. But if the GFR is loss of GFR is more than 25% of the basal level or more than 15 milliliter per minute per 1.73 square meter of body surface in a year, worsening the CKD, you should change your mindset and you should refer this patient to nephrologist earlier. So summary, CKD is present when there is a persistent abnormality of kidney function or structure more than 90 days. And CKD is hidden in patients of diabetes mellitus, hypertension, and in elderly people and outflow tract obstruction. So primary care physicians, they usually go to primary care physicians. So primary care physician's role is very important, even greater than nephrologists, to prevent or delay the process of CKD. And most doctors screen, that is sad on our part, screen less than 10% of their clinic patients for CKD in its early stages. Our conception of CKD has expanded. So role of physicians has really increased. So we being consultant physicians or family physicians or primary care physicians, whatever it may be, we have to be very careful about the delaying the process of CKD. So through population health strategies, early identification and intervention controlling hypertension, type 2 diabetes mellitus, albuminuria, and outflow obstruction carries an immense role. So far, physician's role is concerned in prevention as well as delay of the CKD process. CKD stage 3B onwards, nephrology consultations should be advised. Sustained reduction in eGFR of more than 25% or more than 15 milliliter per minute per 1.73% in 1 year with worsening of CKD category or fall in within 1 year, specialist referral should be made earlier. Thank you for your patient hearing.
Thank you, Dr. Kormakar, for your nice presentation, the interesting topic on prevention of CKD. We'll take up the questions at the end of the session, and we'll switch over to the next speaker.
So our next speaker will be Dr. Tanmay Das. Dr. Tanmay Das is a renowned nephrologist from Guwahati. He doesn't need any introduction, so he'll be talking on recent advances in chronic kidney disease, his personal experiences. Over to you, Dr. Tanmay Das, sir, for your deliberation.
Thank you, sirs, and members of the audience, my seniors, colleagues, and my student friends. Now, Professor Kormakar has given a very outstanding oration, so my job has been made very easy. So I shall just, my talk will not be very much of a medical talk, though I am talking in the Association of Physicians Conference, but it will be a very general talk to show you the paradigm shift in the management of CKD since I joined nephrology in 1986 as a registrar to today. Now, Dr. Swarup Borua, who is present, Dr. Hemchandra Kolita, Dr. Deka, Dr. Nimelanda Bhagavati, Somen Sharma, we were all colleagues and house presidents in the Department of Medicine in 82. We recollect the very dismal scenario that renal failure patients then had. We only had peritoneal dialysis and hemodialysis had just started. Compared to that now, where have we come? So, as Dr. Kormakar has said, it's a very major public health challenge. It's a very big economic challenge to healthcare planners. And because of the aging population and the very high incidence of diabetes and hypertension that we see, now when I joined nephrology, chronic glomerular nephritis was the highest incidence of CKD. Now in front of my eyes, diabetes and hypertension have overtaken. Now every day in my OPD, there are at least 10 to 12 diabetic patients with renal involvement. So diabetes and hypertension have become the two major causes of chronic kidney disease worldwide, and that is also in our state. Now all these we are all aware, diabetes, hypertension, family histories, obesity, past history of kidney disease, nephrotoxic drugs, kidney stone disease, glomerular nephritis, and most important from the perspective of the physicians, the multisystemic disorders which affect the kidney, rheumatoid arthritis, hyperuricemia, multiple myeloma, all will have kidney effects. In fact, Dr. Chugh, under whom I trained in PGI Chandigarh, used to say that medicine is an offshoot of internal medicine, and all nephrologists have to be very strong in internal medicine. So as you can see in that list, general physicians will come across all of this first before the patient comes to the nephrologist. Now, Dr. Kormakar has already said, you can see what is the massive burden of chronic kidney disease in India because of a very large population. The only good thing is that the number of transplants have gone up to a significant number. USA was about 25,000 last year. In India, it's touching about 12,000. But still, it is far, far from what is required. What is interesting in this slide is that you see that more and more patients of CKD are being diagnosed at stage 2 and stage 3. Now, the importance of this is that early detection of CKD has become very common now, and the reason I will show you in the next 2 slides. Now, any patient of CKD crosses all subjects of medicine: general physician, critical care specialist, cardiologist, gynecologist, gastroenterologist, and so forth. Now, I'll give you 2 real-life examples. A lady who was an employee of the Guwahati Medical College in 1992 had severe menorrhagia and severe anemia took blood transfusion, underwent DNC, and subsequently at night, on a very stormy night, at around 1 o'clock, developed convulsion. She was in the staff sick room, and when we went, to our horror, we found that the urea was 300, creatinine was 15, and she was in uremic encephalopathy, but she was under the Department of Gynecology and had undergone DNC for bleeding. So this is a dictum that any patient that comes, like Professor Karmakar had said, with any disease to you, should have at the basic minimum a urine, a creatinine, and an ultrasound. These three very simple tests, which cost less than 1,000 rupees, will pick up CKD very fast. Now, as already known to all of us, prevention and early detection of CKD mandates a very, very strong involvement with the physician, because most patients will go either to the general physician or to the medical specialist first. So CKD patients should be managed by the primary physicians who are trained in their MD course to manage CKD with timely referral, as Dr. Karmakar has said, when to refer the patients of CKD. Now we all know the importance of albumins. It's a very easy test to be done. 40% of patients of CKD are diagnosed based on the urine albumin alone. Now the following three simple tests, as I said, will pick up all CKDs. A urine albumin, a urea creatinine, and an ultrasound. Now these three very simple tests, which is available in every nook and corner of the country now. Every village also has an ultrasound and a good urine testing facility. Now, 1 year mortality of CKD patients on dialysis remains unfortunately at around 20%. 50% of this is contributed by coronary artery disease, strokes about 30%, infections, bleeds remaining. So this is not a very healthy statistics that out of 100 patients of dialysis, 20 will pass away every year of any of these. Now a CKD patient has acute coronary syndrome, left ventricular failure, pericardial effusion, uremic ARDS, conduction defects, dyselectrolytemias, bleeds due to CKD, bleeding diastasis, subdural hematomas, strokes, heparin-induced generalized bleeding tendencies, and uremia-associated bleeding diastasis, which occurs at creatinine above 6.5, and so on and so forth. Now, many of you in the audience will be wondering that a CKD patient, it's a miracle that he survives. But as I told you earlier, the purpose of my talk is to show you how CKD management has changed in front of my eyes. Now, we all know, I cannot put the name, but Hitesh Saikia was a huge political leader of the state, underwent dialysis in his residence in 1981, had a kidney transplant in Boston by his brother donor in 1982, was chief minister for 2 terms, governor for 1 term, and survived nearly 20 years after kidney transplant, when no facility for dialysis or treatment in Assam was available in those days. The government of Assam immediately set up a dialysis unit in his house, and a technician and a doctor from Jaslo came and started the dialysis. Subsequently, Professor Nandita Chudri looked after him. Now, Honorable CM of a neighboring state underwent dialysis in a very critical condition. I went to see him in Shillong when in a cabinet meeting he nearly fell down. His creatinine was 14, and we brought him down next day, put him on hemodialysis, stabilized him, and put him on CAPD. He survived 9 years on CAPD, and he fought re-election from Barapani and won the re-election, because that is the importance and the independence that CAPD gives you. 2 speakers of our states, Jibo Gogoi and Ganesh Kutum, lived on CAPD full lives and fought re-elections. Now Jibo Gogoi fought Khumtai election on CAPD, and Ganesh Kutum fought Gofpur election on CAPD. Ganesh Kutum survived nearly 9 years on CAPD and had was about to undergo a transplant, but he had developed an MI on the table in Gangaram Hospital. Now we think that these are all VIPs and thus survived on dialysis or transplant because money was not a concern. But let us see the next few slides. Now, this lady was seen by me in 91 with renal disease, subsequently underwent transplant in 91. Today, 33 years, she has a creatinine of 0.8, and she came to me day before for a routine checkup. So 33 years after transplant, she's in front of you. Now, this is a school headmistress from Jorhat who underwent transplant in 1992, again seen by me in 1991. Subsequently, after nearly 20 years, she had chronic allograft nephropathy and rejected and survived 10 years on CAPD. So a total period of 30 years she survived on dialysis and transplant, running her school, and she was alone at home, does her CAPD herself, runs the school, does the cooking, because daughter was a scientist who was posted in Gangtok and her husband had died of cancer. Now this is a pediatrician who unfortunately we lost recently. She survived 30 years on transplant. She was the director of health service Arunachal Pradesh at the time of her demise. Again, I saw her in 1992, 1994 she had transplant. After transplant, she had 2 successful pregnancies in our hospital, and this is a recent photograph of hers. Now the lady marked in black, again underwent transplant in 1994, survived 30 years. Now on the day of Durga Puja, when I went to see her, she had acute LVF. She is very close to Arunima Baido's family and stays just next to Borthakur Hospital. So she had acute LVF to the point of frothing from the mouth. We put her on huge decongestive therapy at home of Lasix 200 mg, Dexona, Derifile, etc. and brought her down to Borthakur Hospital because that was the closest hospital. She was so sick, subsequently stabilized, underwent transplant in 1994 and lived 30 years. All the girls were married, were then in frock and in school, in class 2, 3. They have all grown up and the mother survived 30 years. So this is possible in Guwahati. These are all persons known to us, next to us. Now this is the first lot of transplant patients in our hospital done in 2010. Dr. Soria is there in the middle. Now this is a file photo recent of very happy transplant patients of various durations. All have been done in a hospital. This was a recent patient transplant meet which we had. Now CAPD also gives you very excellent outcomes. Now this lady, the wife of a senior IAS officer, 82 years. She was diabetes, hypertension, CKD5, huge LVF, huge accelerated hypertension with coronary artery disease. So she was stabilized on dialysis, and because she did not tolerate hemodialysis, we required to dialyze her every second day, and still then she continued to remain breathless and she was always propped up at 90 degrees. We put her on CAPD and she did well on CAPD. That is a photograph of CAPD. This gentleman came from Banaras. Again, he had the same elderly gentleman. He had diabetes, hypertension, chronic kidney disease. He had coronary artery disease. We had done PTCA on him. And the patient used to have recurrent shortness of breath, hypotensive episodes, chest pain during hemodialysis. So we decided as a policy to put him on CAPD. And we put him on 7/8/2023, and this is a recent file photograph. He does a CAPD himself and is quite happy now. Now this lady is a special lady. She has very few diseases. She has end-stage kidney failure on dialysis from Dibrugarh. She has coronary artery disease, very severe, and she has, if you want anything else, she has chronic liver disease also. So end-stage kidney failure, coronary artery disease, and chronic liver disease. So she was started on dialysis in Dibrugarh, and you did not tolerate Dibrugarh, they did not tolerate the dialysis very well because of all these comorbidities. We did a coronary angio, found to have triple vessel disease, did a death on table consent, coronary artery bypass graft on 25/4, triple vessel graft on 2023, and we subsequently put her on CAPD on June 2023, and she is doing very well now. She is very active at home, regularly has video conference with us, and she's urine output is also better. And this is another case who was ventilated 4 times, twice in a hospital, twice in Marwari Maternity Hospital, and subsequently we put him, he had a death on table consent, again bypass, subsequently put him on CAPD catheter on 29/7 because he was not tolerating hemodialysis, and he is doing very well. This is a recent photograph. Now this just shows the peritoneal dialysis in patients with refractory congestive heart failure is a very good option too. Many would think that hemodialysis is better, but CAPD has a very good outcome. I'll skip all these slides for shortage of time. Now this is that ventilated patient's son's marriage, and the recent marriage, and the father was proudly attending the son's marriage. Now this lady from Mokokchung was put on CAPD, survived 13 years. Had we not put her on CAPD, she would have died, because Mokokchung did not have dialysis facility, and the nearest dialysis was Kohima, which was 3 hours away. So we put her, and she survived 13 years on CAPD. Unfortunately, she did not have a donor, because her elder brother had undergone 2 transplants and is still doing well. After transplant, he's had 2 children also. This is a file photo of a dialysis unit. Now, these are the figures what we have done in International Hospital and Apollo Hospital. We've done about nearly 1.5 lakh dialysis. We've put nearly 2,000 CAPDs, and we run a very regular transplant program. So in 1986, when I was a senior registrar in Guwahati, things are not very good. Now things are much better. In 1990, when I passed GM and came, there were only 2 dialysis centers in the Northeast, one in GMCH and one in downtown. Currently, under the Prime Minister's dialysis initiative, we have 48 dialysis centers, and we have 13 medical colleges. We have a huge number of dialysis available everywhere. And just 2 days back, a deceased donor transplant had been done in GMCH, which opens a new chapter in the management of kidney disease. We've started postdoctoral training along with GMCH and creating faculty for the nephrology. I think I'll stop here. So I wish all of you a happy Christmas and a very New Year.
Thank you, all the 3 speakers, for maintaining their stipulated time and for delivering a brilliant talk. So we have come to the end of post-lunch session. This is a mixed bag too. So we have 3 minutes left. So we'll take 1 or 2 questions from the floor.
Yeah.
Sorry, sir, I just stepped in ahead. Thank you, Karmaka Das sir and Trid Das sir for wonderful lectures. So I had one query with regards to CKD. Early CKD, it's very difficult. The diagnosis depends on criteria. So EGFR, what is validated in India? Because there was a 2018 study which of PGI-IMER, which says that there is no criteria which is validated for Indian population. Even in 2023, this criteria is not established in Indian, any of the criteria, whether it's CKD EPI, whether it's Cockcroft-Gault, or any criteria are not validated for the Indian population, overestimates the EGFR in the Indian population. Thank you, sir. This is my question. Which EGFR should we use?
My question to Dr. Karmakar regarding use of metformin in chronic kidney disease. At what level of creatinine or at what stage metformin should not be used in chronic kidney disease?
Thank you, sir. So first time I am addressing that young boy who addressed for calculation of EGFR, definitely what you have said, that is absolutely right. It definitely varies from one method to another method. But CKD EPI is very accurate, because if you want to get the accurate EGFR, you have to go for cystatin C excretion. So that is not possible. That is could be done only few of the specialized centers. So CKD EPI could be almost very near to the accurate EGFR. And coming to the second,
Thank you.
Sir, your answer to your question, you have asked me at what level of creatinine we should stop using metformin. So it varies according to the sex. It is 1.4 in male and 1.3 in female. Above that creatine, better not to use metformin. If Dr. Tanmay Das having any other opinion, then please come. Okay.
Yes, Dr. N.G. Singh, please. Please switch on the mic.
Hello.
Yes.
I'd like to ask Dr. Trideep Das, is a nice presentation. Like mass is the diagnostic criteria what's shown in the slide. And if you go for the HLS, also diagnostic almost similar. My question is whether both are synonyms or management is same, or what we take, or it is a newer term. And my next question will be to the Karmakar sir. Sir, I like to hear from you about the find on today, the molecule for the prevention of progression of kidney disease.
Can you repeat the question actually?
So you have shown in your slide the mass
Yeah.
in the child, in the topic of the GIA.
Dr. Karmakar.
So if you put the diagnostic criteria, those who have shown the diagnostic,
it is almost
increased like ferritin and you got other criteria, platelet count less than 180, that become very dicey because in our place platelet is always around 150 only. Anyway, my question is whether GIA, mass and HLS can be used as synonyms of the same term, or is it a different term?
These are synonym basically, and the treatment will be, our diagnostic pattern will be similar almost, and the treatment will also be similar in both the cases.
So we should be very much tricky while using that mass.
Yeah, definitely.
Because the basic difference between the two is, one is mass is because of only rheumatologic causes. HLS can be from the secondary other causes also. It may not be the, definitely in the background of rheumatology, but other part will also be there. So in the HLS, criteria will be the same. But you should keep, while treating the mass, you should keep in the mind of the HLS also.
Yeah, definitely, sir.
Because that you're going to treat the triggering the viral part also.
Thank you so much. Thank you.
Your second part of the question on nephrology, the molecules used for prevention or progress of CKD, isn't it?
Yeah, like on the actually new molecules, sir, Karmakar sir, I like to just hear you from you about the fine on the molecule which have been talked today for the prevention of progression of reducing the proteinuria and slowing the progression of CKD. Where to place it and whether we should practice today or not.
So from 1988, when I met Professor Carl Mogensen in PGH Chandigarh, he had come as a visiting professor. Since 1988 till now, we are still discussing, debating different molecules. So many have come, so many have gone. Finerenone is now, it is just coming very shortly. I am part of the National Committee for seeing the efficacy of finerenone. So I think the consensus is some more time should go before we see its efficacy. Because prior to this, so many drugs have been postulated and they have all gone. And the progression of chronic kidney disease is just slowed down from maybe GFR decline 1 to 0.8, but we would want it to come down further. So as of now, I am not seeing any very active molecule to reduce. Many would say that keto amino acids are useless, but I find keto amino acids are very good to keep the creatinine under check. We have a lot of patients, elderly patients, where the creatinine has remained reasonably well. It is not a wonder drug, but I would be little hesitant to recommend finerenone now because just 2 months back we had a review meeting in Calcutta, about 10 of us from all over the country, and we said that some more time should go before we find out and recommend that it should be used. But there is no harm in trying because anything that slows down the progression is good. Similarly, the new antibiotics, Avatox or Zevitox, which have been recommended now. So my experience is very less. I'm waiting for others to give a longer follow-up. So at least 6 months to 1 year of use, and then only I would think of using. I'm not at this point of time using either of the two molecules.
My question is to Dr. Tanmay Das, sir.
in the cases of CKD, already known CKD, in what conditions, in what clinical conditions or biochemical conditions we put a patient for dialysis, especially hemodialysis?
Now, in our Davidson textbook of medicine, which we read in 1980, it was urea above 200, creatine above 8, bicarbonate below 15, potassium above 6, and acidosis. So these were the few criteria. But today, we don't go so much by the biochemistry. We go by fluid overload, pericarditis, acidosis severe, and uremic encephalopathy. These would be the absolute indicators. Yesterday morning, just before coming, there was a patient from Tezpur who had the urea of 539 and a creatinine of 20. So he obviously would have to go immediate dialysis. But we don't base urgent dialysis on the biochemistry so much nowadays, unless there is hyperkalemia, severe acidosis, which is very adverse effect on the heart, or gross fluid overload, which is life-threatening, or pericarditis, or uremic encephalopathy. Then we would go. But these were the textbook recommendations which we studied in Davidson's textbook of medicine in 1980-81.
Thank you.
Thank you, sir. With this, we'll close this session. But there is a minor change. I request the organizer to announce the changes in the program.
Yes, sir. Sir, thank you so much. Actually, we'll be continuing the session. The change is that we have our respected Anup Burman sir with us. Sir's talk was originally supposed to be held tomorrow, but due to sir's busy schedule, sir has asked us to reschedule the talk. We'll be having it now in continuance in this session with permission from the chairpersons. And they have kindly agreed to chair the session. It's my pleasure to invite Burman sir.
Yeah, I request Dr. Anup Burman sir, please come over. He will be talking on lupus nephritis management update. I think Dr. Anup Burman sir has no introduction to this August gathering. He is presently Director of Medical Education, Assam, and a renowned nephrologist of Assam. Sir. Dr. Anup, please.
Good afternoon to one and all present here. My esteemed teachers present here, and respected chairpersons, senior colleague, my students and friends. At the outset, I must thank the organizer for having me here today. In fact, I supposed to deliver tomorrow, tomorrow, but because of my schedule, I have to come and then to deliver on the request. I thank our organizing chair for giving me or for allowing me to talk. I'll be speaking on a very important topic, is lupus nephritis and management. Because lupus nephritis, it's a very huge chapter. In the 15 minutes, it is very difficult to cover all the things. So I'll be touched upon only some of the salient points here only. So lupus nephritis, as you know, the SLE is a very common disorder. It's a global public health issue because there is no cure, that I have to say. But with a good therapeutic intervention, we can achieve remission, and also we can have a disease and free flare of disease. So treatment is very important. So although there is no cure, but we cannot live alone. And it's lupus nephritis and infection is perhaps the commonest leading cause of mortality amongst the SLE population. So treatment is very, very warranted in such patients. And in most of the time, then lupus nephritic patients are maybe asymptomatic. So a very high index of suspicion is required for early and prompt diagnosis so that we can institute our interventions at in the right time with the right direction. And so it is mandatory to order for a urine examination. Very simple. Just you order for a urine examination in such patient whenever you diagnose to have a lupus or whenever some features of lupus are present. And then that's the most important thing is in proliferative versus non-proliferative, because the proliferative disease we have to differentiate clinically most of the time, because don't go directly to the biopsy. It will take long time, maybe 5-7 days to diagnose. So you have a very clinical sense to diagnose whether the patient is having a proliferative disorder or a non-proliferative disorder. So because we have a different mode of therapeutic intervention that. So that's again a careful attention by the physicians. Whether you are dealing with a proliferative or a non-proliferative. Proliferative is really, you need an aggressive therapy just to prevent an organ damage. And renal biopsy, of course, is the paramount for the best practice guideline, best practice therapeutic interventions we have to do. Although many physicians may not agree, but we as a nephrologist, we always go for a renal biopsy, because unless we have a biopsy on such patients, it is very difficult to treat. We cannot really fall into the guidelines. So the introduction of my topic is again, then and then 50% of the patient with lupus may have, and the SLE patient may have lupus, and then 5 to 15%, say around 10% may have an end stage even with the best of the therapeutic interventions. And the incidence of lupus is mostly in Black and Hispanic and mostly in Asian population. And although it is in 30% in white, 60% black as I showed, and 40 to 80% in Asian countries. It's very common in our country also, in our country as well as in this part of the country. And then it is, the incidence and prevalence of difference is usually influenced by age, gender, ethnicity, geographical distribution, and diagnostic criteria, etc. These are some risk factors where there may be a progressive kidney disease. We can predict that this group may, when there is a severity of the clinical parameters, with a high degree of proteinuria, there is a reduction of the glomerular filtration on the onset of the diagnosis, then the low level of very complement level, then very high titer of anti-GSDNA, and presence of AFLA or AFLA positivity, and of course, when there is a high index of chronic or high chronicity index of the high is very high, then of course we can predict probably these patients may go into a end stage or chronic kidney disease in very soon. And last but not least, it is the non-adherence to the therapy. So this is very important in all in clinical settings. So we have to assess the patient's compliance. Then why do we need to treat again? So what is the goal of treating such patient? First thing, as I said, the lupus SLE is not a curable disease, but we must treat to preserve the renal functions, to preserve the renal flare or the prevention of the flare of the disease, and avoidance of treatment-related toxicity, etc., and also to improve the quality of life, and of course, last but not least, it is just survival of benefit. So these are very important, and of course, the intermediate part is to achieve whether it is a remission, whether it is a complete remission or it is a partial remission. Anyway, we have to achieve. This is our goal of the therapy. Now, how do we assess the goal line? This is go by. We go by this KDIGO. I say that KDIGO is our, we follow. This is kidney disease improvement in global outcome. That is guided by the International Society of Nephrology, and we usually follow. Or you can follow also EULAR, but more of time, by and large, the EULAR guideline and KDIGO guidelines are similar. So we can follow. But still, as a nephrologist, I would like to follow the KDIGO guideline. And where then urinary protein creatinine ratio is less than 5, when you achieve within the first year of life, first year of lupus treatment, then we can say it is a complete remission. When reduction after the 50% in 6 months, then we can call it is a partial remission. And when either or both of absent, then we call it is a non-responder, or we can also be refractory. So we have to think in that way. Again, what is the principle of treating such patient? Principle of treating a glomerular disease is same, because basically lupus is also a glomerular disease. So the treatment, what we follow for other glomerular disease, same also lupus also, like lifestyle modification. These are the preliminary. Then starting of the RAS blockade, AC or ARB, if they are hypertensive. Even though if they are not hypertensive, low dose of RAS blockade may be helpful for reduction of proteinuria, but we have to see whether BP is well controlled or not. Because if they produce an hypotension, probably not to use the RAS blockade. It may cause another effect. Then diuretics, of course, if required. And then statin, you should use to control the lipid profile. So these are the general instruction, and also general like vaccination of the patients because they are immunocompromised patients, so they should be vaccinated like in any other chronic kidney disease. And then other treatments should be followed. But the most important is the specific therapy. But specific therapy, it is guided by the biopsy, and then it will fall into the guidelines. We will talk to the next few slides, maybe on that slide only. So current practice, what is the current practice is in lupus patients, current practice we phase in two phases. One is an active phases, that is one the induction phase, and second is in maintenance phase. Into this induction phase, basically it is to prevent an organ threatening. We can prevent an organ damage. And what is the maintenance therapy? It is basically to consolidate the remission and at the same time preventing of the relapse. So with this, we start a treatment, and with a better understanding of the disease in molecular insight, there is a paradigm shift in the treatment of the lupus in the recent years. And there is a more specific therapeutic intervention has come up with the lupus. And then current standard of care therapies in treating guidelines, and there are a lot of guidelines today has come up, but it is an old time tested guideline is in American College of Rheumatism. That is the old guideline. Subsequently, the Euler guideline from Europe and from the KDIGO since 2013 from our International Society of Nephrology. And as I said, as a nephrologist, I always love to use this KDIGO guideline. And also that Tanmay Das sir is also here. He will also agree with me that always you go by the KDIGO guideline. So the current practice in the steroid, there is since 1950 first started. Steroid is a gold standard, is no doubt. It is a cornerstone, and it is the bridging therapy in an SLE patient or lupus patient as a whole, and also lupus nephritis. And it was started, and since 1970 to 1990, in those periods, cyclophosphamide was introduced with the heavy outcomes. And that was the first trial, it was a NIH protocol. And that was probably a turning point in a lupus therapeutic intervention. National Institute of Health, this is a study from the UK first initially, have shown an 80% stable kidney function is a long-term with cyclophosphamide in a 2-year course, and achieved a 65% stable kidney function with a short course cyclophosphamide, whereas only 52% only on glucocorticoid. So you can easily appreciate here the use of cyclophosphamide. But the thing is that cyclophosphamide is not a drug without hazards. It's a very hazardous drug, as you know. So considering all these points, some other drugs, new drugs has come like MMF. In 2000, MMF has introduced, but prior to that, MMF was introduced in the transplant medicine. Later on, its use in the SLE also has come, and it has shown a very good result. But most important thing is that side effects are very, very low in compared to the cyclophosphamide. So people started using that MMF after the cyclophosphamide from 2020. And in 2002, that another landmark trial have come to us, that is a Eurolupus trial. And this has also, it is also revolutionized in the treatment of therapy. Basically, it is a modification of NIS protocol, what we follow. Because in NIS protocol, there is a lot of immune toxicity because of the cyclophosphamide. As you know, cyclophosphamide is a gonadotropin, and most of the lupus patients are then female patients in the reproductive age group. So they may have infertility in later, even they go for pregnancy, the treatment failure is very, very high. So considering those points, probably cyclophosphamide in high dose for lung continuity was not warranted. So that's why the Eurolupus trial has come, and Eurolupus is really a wonderful trial, only 6 courses of cyclophosphamide 500 milligram every 2 weeks for 6 doses, and then subsequently we convert to the MMF. So this has come, and probably still, I think we all love to use again the Eurolupus nowadays in such patients in active lupus. Then calcineurin has come but calcineurin is a drug only as a rescue therapy when there is a refractory type of, and along with other immunosuppressive, we call it a multi-targeted therapy. In 3 drugs, steroid, calcineurin inhibitors, and MMF. If you combine all 3 drugs, we call it a multi-targeted therapy, and this is also a wonderful regime within some of the benefit to the patient. The other drugs is in rituximab. When it comes fast, we thought it could be game changer, but now it is considered that it is not a game changer, but these drugs doesn't have any added benefit over the conventional therapeutic intervention. So it is just only for those where there is a refractory type of lupus. So as a refractory, as a rescue therapy, perhaps rituximab can be used in such patient. So we do not use as a first line of therapy drugs for rituximab for the lupus patient, only as a rescue therapy when another first line drugs failed. Then another drug is a monoclonal antibody, that is belimumab. Belimumab drugs, we got it from the BLISS and trial. Also, it could be another wonderful molecules, which is not very readily available in India. Perhaps could be helpful. And recently in 2020, FDA has cleared the drugs for the use in lupus nephritis. We don't have practical experience, or also don't have much study on these drugs. Then another is in baclosporin. Basically, it is a CNI, like in cyclosporin or tacrolimus. It has a better, sorry, I'll take only a few minutes on this, sir. So, yeah. So these drugs also can be used as an CNI substitute because it has a lower nephrotoxicity, and new onset diabetes is very, very low. So the indication of biopsy, as you know, when you go for the treatment such patient, we should always go for biopsy to stage. Like this, these are the staging. All you know, I need not to speak because you all know about the staging in WHO or then IN, ARSEN 5, 6 classes, and you treat as per the guidelines. So induction phases, first, in the class 1 and class 2, you treat like a, if it's a proteinuria is less, you take just without any high dose of steroid. You can treat only hydroxychloroquine, this is the drug of choice here on the track, along with the steroid if required for the other extrarenal manifestation of lupus, otherwise not for the kidney. Similarly, if it is a nephrotic syndrome, heavy proteinuria, then we have to use then bolus of nephrotic and steroid along with other immunosuppressive like azathioprine or MMF. So this is in class 1 and 2. Otherwise, in class 3 and class 4, you should be treated very seriously because these are the drugs can eventually may lead to a chronic kidney disease if you do not handle properly. And these drugs require an immunosuppressive, which is a bolus steroid as per the KDIGO. So bolus steroid followed by urolupus therapy. As I said, urolupus is the best practice here to start with in class 3 and class 4, so prevent an organ damage, and along with as a maintenance of azathioprine or MMF. And we usually prefer, nowadays MMF we prefer as a maintenance therapy because of the lower side effect. And class 5 is a membranous type. Here we should treat the patient with like in any other nephrotic, in the membranous type of nephrotic syndrome, only steroid. It is because it is a course, is an indolent course. We will have a lot of time, but not cured, but it will have a lot of time. So the end-stage renal disease may occur after 20 or 30 years of life. So we can wait here. But in class 2, class 3 and class 4, we cannot wait because it is very aggressive disease. Then this we can skip. Then in the maintenance phase, I just said, maintenance phase should be started why it should be started? Because to consolidate the remission and to prevent the relapse. Usually maintenance, I just said, and azathioprine is a drug of choice for our economic condition, considering our economic conditions, but we can also use the MMF if it is permissible. Then these are some other thrombotic microangiopathy we will not discuss because of paucity time. Now, what is the duration? 36 months usual durations for the KDIGO, and you will have also 3 to 5 years of duration. And now then, when do we draw the treatments? When do we stop the treatment? Again, then the question of biopsy will come here. In lupus nephritis, if it is a resistant type of lupus, you should go for a biopsy. If the biopsy showed then a very high index, chronicity indices, there is a severe tubular atrophy, glomerular sclerosis, and interstitial fibrosis is more than 50%. Perhaps treatment will not suffice. So then we should reduce the dose of an immunosuppression and prepare the patient for the kidney transplantation. That means we should go for maintenance dialysis if required when the patient go into the end-stage renal disease, and when the disease is not active, and rather to do a biopsy, see that where there is no any features of activity, then you should go for transplantation. Now another question will come, when you should go for the pregnancy. Can a lupus patient go for pregnancy? Lupus patients are never infertile, they are fertile. Only thing is, but a successful pregnancy with an active disease is very, very unusual, very, very uncertain. So the disease should be controlled at a remission at least for 1 year. Though this book has said in 6 months remission, but we would prefer to go for at least 1 year disease free then you should advise for treatment. And before pregnancy, we withdraw the cyclophosphamide. We can continue as an azathioprine, not MMF, steroid, azathioprine, and hydroxychloroquine. These 3 drugs are safe during pregnancy, so you can continue such patient. So these are the poor prognosis, we all know. So with this, the take-home message I'm giving on lupus, although it is a disease, not uncommon disease, no cure, but treatment should be prompt and appropriate. A high index of suspicion is required for the SLE diagnosis, a lupus nephritis diagnosis, and a class 3 and class 4 especially, because they need a prompt and appropriate therapeutic intervention that can be prevented to going into the end-stage kidney disease. That's all about my talk. If you have any questions in your mind, please.
Thank you, Dr. Anu Burman, sir, for your brilliant deliberation. We'd like to have 1 or 2 questions from the House. So before that, I would like to ask Dr. Anu Burman, sir, that, see, SLE treatment, there has been tremendous progress. Even then, a complete remission or a cure is still elusive. Do you think that anti-CD19 CAR T-cell therapy in the future will hold a cure for SLE patients? Your opinion, sir.
Right, very good question, actually. In fact, the therapeutic intervention, as I said, whatever we use after a remission, after a consolidate remission, our motto should be to prevent the disease flare or to relapse of the disease. But the best drugs insofar in a time tested is hydroxychloroquine and continuation of the low dose steroid with or without MMF or azathioprine. This is a still gold standard therapeutic intervention for the prevention of relapse or prevention of flare up of the disease. But the other molecules, like other molecular antibodies, they have much role. I don't know, I don't have it, but these drugs are used as a second line of therapeutic interventions because these drugs don't have any first, and these drugs are, as I said, whether there is any role of monoclonal antibodies or any role of rituximab for a disease prevention or disease flare up, that we don't have really in this moment, we don't have any literature available, but probably maybe later on it can come in big way. But when the rituximab came into the clinical practice, it comes in such a way, that time we were in the impression that it could be a game changer. But after last 3-4 years, we have seen there are a lot of, even Euler study, Euler have shown that there is no added benefit of rituximab as a primary intervention, therapeutic interventions in compared to the cyclophosphamide or azathioprine.
Thank you. Yeah, we'll take one last question from Dr. Anjit Singh.
I'd like to ask Burman, sir. Sir, the vaccination, the usual vaccination, what we do in the adult, we follow that vaccination. I just like to refer you, take your attention about the pneumonia vaccine. As immunocompromised, below 65 years, we recommend, usually a few guidelines say they should go for polysaccharide vaccine 23 once, and after 65 that should be there. My question is that whether in case of lupus nephritis patient, how we should proceed for vaccination, especially the pneumonia one? Whether they should be repeated every 5 years, or whether we start with conjugate vaccine and follow up with the polysaccharide vaccine?
The vaccination schedule is as per our guideline is as like in our chronic kidney disease, what we follow is actually like for starting from hepatitis B vaccine, because we have to prepare the patient for eventually, if not recovered, not in remission, he or she will go into a state of chronic kidney disease later on. So we have to prevent all aspects. We have to see. So we start from the hepatitis B, then also influenza vaccines, and then pneumococcal vaccine. We have to start all the vaccination. So we go by then as our protocol. Usually they are conjugated. In what we say that is 23 that covalent vaccines are commonly used. We do only in 5 years. Whether you should repeat or not, yes, ideally you should repeat every after 5 years. Like influenza, like in 1 year we can repeat, but pneumococcal vaccines can be repeated after 5 years. You should continue. But vaccination is very important because, as I said, these people eventually succumb to a gross severe infections. They may succumb to a severe pneumonia or any other infection, which can be prevented by doing a vaccination. So should be done.
Thank you so much. So we declare the session end.
Thank you.
So before that, we request the organizers for a mandatory group photo.
13 first and then 23. Usually Revar 13 first, 8 weeks later 23. Do you accept that?
I request the speakers of the previous session also to come over for a photograph, group photograph.
I would like to thank the speakers for their excellent deliberation and the respected chairpersons for conducting the sessions so well. Next, we have a cardiology panel discussion lined up for you. To chair the panel discussion, I would like to call upon the dais Dr. Nipen Datta sir and Dr. Amiyo Kumar Sharma sir. To moderate the session, we have none other than Dr. Deepak Sharma sir, and we have Itzikalita sir, Dr. DJ Datto sir, Dr. Nitya Gogoi sir, and Dr. Uttam Nath sir as the panelists for this discussion.
Good evening, everyone. It's really heartwarming to come to Tezpur and seeing so many seniors and my classmates as well, though they may not be physicians actually. We are enemies like surgeons, like my dear friend Manav Goswami. And of course, Ramada is there, our Sar, Guru, as well as friend. So anyway, I think after a very interesting and complex, what I think very complex session of nephrology, let us discuss something very mundane, but sometimes can be quite intriguing, because it is a session on hypertension. Either we suffer from it ourselves, or we treat hypertension in our relatives, our friends, and everyone. And so we need to know hypertension in a little bit detail, and for that we have a very august panel here today. And of course, Professor Kalita is there, Professor DJ Datta is there, Dr. Nitya Gogoi is a very experienced physician, and Dr. Uttam Kumar Nath, the young Turk from Jorhat, a rising star in API, Assam branch. So anyway, I think, what I decided today, that, we'll pick up a new latest guideline. The latest guideline is 23 guideline of ESH, European Society of Hypertension. You might question why I have chosen this particular guideline. I've chosen it because it's new, and European guidelines are a little relaxed, and it tallies with our own guidelines. And I think till the 24 Indian guideline comes, I think we'll have to, I'd like to follow it myself. So it's about a 200 pages document, so it's not possible to go through all of them. So I thought, let us see what is new in this guideline. First of all, what is new in this guideline? When I went through it, I found that, there were more, I think they tried to make it easy. Their idea of having this guideline is that, they wanted to make this guideline easier and simpler. So in some regards, actually, they have succeeded. And, but, what is their definition, or what is the threshold for treatment and what is the threshold for diagnosis of hypertension? They kept it simple as 140/90, like in all other guidelines, in Indian guidelines of 2019, ISH guidelines 2019, the threshold is 140/90. The target of treatment is also same as before in most of it. It's unlike JNC 8 and the American College guidelines. It is now 130/80. So that is in general. And another thing which is new here and which is close to our heart as Indians is the role of beta blockers. They brought beta blockers to the forefront of the diagnosis. I have not kept any slides because, I think by this time we are all a bit, seen a lot of slides today. The idea is not to show me there, actually. So if you can take it off and focus in on the chairpersons, it'll be nice. Anyway, so the other thing which I liked about this guideline is that they had, addressed particular age groups. In particular, the adolescence age group, not adolescents, age group between 19 and 39 or 40. This is a group, which is young adults, which was not addressed by in any other guidelines. So I think we have our panelists here. We'll ask them a little later. The other thing is that they have also chosen some comorbidities. Of two comorbidities I like, I think Dr. Sangeet Datta is here. NFLD is one, thing they have focused very well in this guideline to see that, whether, they have any particular, implications in course of hypertension and complications. The other, of course, they have addressed is the air pollution. So I think since all of you are experts in hypertension, I recruit you as panelists to this discussion, all of you. So the other thing is that I think I have asked Piyush to circulate some papers. If you have any comments or query, please jot it down, and Piyush will collect it every 14 minutes. We'll try to address this question. Our panelists will try to address this question. Now, first thing, I think, Deepak, can I ask you about this situation I mentioned about the young adults, age group of 19 to kind of 40. Sorry? Yeah? 19,
yeah.
Age group of 19 to 40. Do you have any real data about how do you go about treating them?
Deepak, before commenting on the question, with due honor to the August gathering, I must confess one thing. In majority countries, Western countries, they have got hypertension specialists. But India, we do not have as such hypertension specialists. All physicians actually, they can consider themselves as specialists, because once the patient comes to them with the problem of hypertension, they will always try to do their best to control their blood pressure within control limit. So in that sense, I think all of us sitting here is specialists basically, and will require your input as well, because all of you are quite adept in managing those patients of hypertension. Is such a common disease. And as per our chairperson's question, not question actually, the one aspect of hypertension in our population is the young adult. Actually, when I have gone through the literature, the definition of young adult again is variable. I mean young hypertensive. Some people have considered 30 years, some 40, some 50. So what by and large the ESC guideline, whatever they have suggested, 19 to 39 years, or that is quite reasonable. In this is the most vulnerable period. And by all statistics data, what we have seen, the number of incidence of hypertension at this age is just growing around 10 to 15% at best. At present time, our national average high blood pressure across all age groups is around 27%. That again, there may be a lot of debate about that regarding the nature of survey and the type of study. There's so many variables are present here. So by and large, 1/3 of the Indian population, adult population, are hypertensive. And by the same token, the number of hypertension in that age group is not so small. But the question is that, are we being able to address them properly, and whether we are treating them well or not? Because honestly, if we are living in a age of evidence-based medicine, to detect and treat those patients in that particular category, there is not enough data. That is quite surprising. There are some data mainly from Korean countries. They are addressing this population group. For Indian data, I am not very sure. Maybe Kolita sir can highlight on that.
Can I just interrupt you? I think there is no data, not only Indian data, there is hardly any data worldwide except the Koreans. Even the Koreans, some of the Korean data are very confounding. Because one Korean study of more than 1 million patients said that, young adults, they said that, if you should treat them so to prevent the further complications of CVD, which is, I think, a common sense. But another study showed that there's no significant difference if you didn't treat them, or, the risk of developing hypertensive complications in the future, even if you treated them, it doesn't reduce that much compared to the normal population. But I think, by and large, we have to treat them. Though we don't have the data between 19 and the 39 years old people, this is because all the RCTs, they recruit people from about 40-ish. And then, carry it on till about elderly and very highly elderly. In some RCTs, they have, young people in their thing, but very meager and very few data on that. And in fact, there is no risk calculator for this age group. That's an interesting thing. So yes, he has suggested that we should have more RCTs, we should have a risk calculator for this particular age group. But till such time, I suppose, we treat them and we extrapolate the data from all the studies of different age group and start treating the patients. But it's high time, I think, there should be studies, particularly in India, because young Indian people develop hypertension at a younger age group. I think, as Dr. Dutta has already said, Professor Dutta has said.
Just a minute, regarding the risk stratification, Dipakda.
Yeah.
So in older individual, it's quite common, as chairperson has suggested. But in Indian context, the risk calculation basically for future cardiovascular disease. So cardiovascular disease means stroke, heart disease, as well as peripheral arterial disease. And some people are also including plaque in the aorta. That is also a part of a vascular events, which can predict the future vascular events in that particular individual. So risk calculator in Europe, they are having a Euro score. In US, they are having a pool cohort equation score and Framingham score. And UK, they are utilizing the GBS score, the Great Britain score. And many people are probably thinking that GBS score may be applicable to our population. But and that is why they have gone for not a short-time risk calculation. Because by virtue of age in young individual, 10 years risk calculation is very minimal. So with that background, it's very difficult to advise them for treatment regarding their control of mild to moderate hypertension. But in those populations, we are supposed to calculate for a 30 years risk. If we can calculate the 30 years risk, that may be more practical. Anyway, opinion may differ. So,
yeah, I think there's, till today, there is no definite,
Dipakda, in reality, if you see our background, our society background, I'm not talking in Jorhat or Dibrugarh, or Guwahati is far better for us. In the rural area, what is our gap? Our gap in hypertension is, first is detection. Detection is tremendously poor. So that is one. Secondly, even if you detect, control. Exceedingly poor in Indian data. Hypertension, one article was published by Prabhakaran and Reddy in hypertension around 10 years back. We have our own data also. In Guardian people, 13% are known to have hypertension. 1.6% are under control. Those who are, that means out of 100 hypertensive, only not even 2 are under control. In tribal people of Assam, around 32% are known to be hypertensive, 23% are under control. Less knowing also hypertension, they are not controlled. In Mizoram, it is better, nearly 40% of them known to be hypertensive, out of them around 50% of them are under control. So, real scenario in our country is, forget about calculation, first is detection.
Yeah, absolutely.
So that should be a major gap, in our society.
But very interestingly, not only in our society, it's in the advanced countries as well. There's a rule of half. We we don't detect half the people that they have hypertension. Even if we detect them, half of them are not properly controlled. And when we try to control them, half of them are not controlled. So I call it a doom of half. So I think, in particularly India, I think situation is particularly much, much worse. The worst scenario is that, though the previous data showed that, the urban areas have more prevalence of hypertension, that is changing now. The rural area is also converging. The data has been converging, and so I think it's a very burning issue. Apparently, it's very simple, but it's very difficult to address these issues, how to address them. I think Professor Kalita did a study with ICMR on salt and hypertension, and I think perhaps if time permits, you'll be able to talk a little bit about it in the future. But another question is, we have targets, we have thresholds, but how low should we go? Is there any idea how beyond which we shouldn't go down, or? Yeah, I think you can say that. No, I think, if any one of you want to, jot down your queries and comments, most welcome. I think we'll collect it very soon. Piyush, I think, is, running around there. It's interesting. Everybody treats hypertension. You see, that's why we've chosen this topic particularly today, so that, we can learn from you as well. So you said 120 and 70?
120 by 70.
Okay.
Earlier studies have shown that if you decrease the blood pressures by 20 by 10, above 110, you get the desired benefit in a patient when you start giving treatment to that patient. And the recent studies also shown, even the ESC guidelines also said you will not get any benefit if you lower the blood pressures beyond 110 and beyond.
Very interesting thing happens here. Suppose somebody is not hypertensive and his BP is, say, about 110 and 66. So what do you say to this patient? What do you say to this patient?
Deepak, I have a comment in this. Now, there are some trials because earlier when we were students, there was Jacob. Then Jacob has gone. Then the idea came that lower is better, lowest is best. Now Jacob has again come. Particularly in elderly, particularly in those very persons who are already known coronary artery disease or expected to have coronary artery disease. If you reduce the diastolic blood pressure below 70 and systolic blood pressure below 110, there is a tendency to increase the mortality. Particularly because in coronary artery disease, as you do know, the coronary artery filling occurs during diastole. So if the diastolic pressure is too low, then it is expected that particularly at night, normally also blood pressure drops, so diastolic blood pressure will further fall, coronary flow may be decreased. And it is expected also on epidemiological study that if blood pressure is below 70, then tendency to have more coronary artery disease and death is more. So once we treat, but unfortunately in practical purpose, if we have a patient of 70 years, his blood pressure is 170/60, and you need to decrease the systolic blood pressure. What to do? His blood pressure is already 60. But we know that in elderly person, systolic blood pressure is the primary determinant. In fact, I would like to, if time permits, I would like to quote one very recent trial. In August, NEJM published one article, Global Cardiovascular Risk Consortium. They have had the collected data, 114 cohort out of 43 countries, considering 21 lakhs people. And they have shown that conventional reducible risk factors, that hypertension, diabetes, smoking, obesity, and sedentary habit. If we can take care of these five, before that, these 5 factors contributes 57% out of all global burden, cardiovascular global burden. And interestingly, 29% in female, that means half of that, and 22% in male are contributed by systolic blood pressure. So in an elderly person, systolic blood pressure is very high, diastolic is too low. Systolic blood pressure is a prime determinant for adverse events, both in stroke and cardiovascular disease. So we should try to reduce, but reduction should be slow, tempting to not to reduce diastolic blood pressure too much.
Yeah.
At the same time, from 170, even if you get 160 or 150, he'll be much benefited than on 170.
So the question I was asking actually, suppose a lot of patients come to us and say, some low blood pressure. So what do you do that? What do you tell them? How do is there a condition called low blood pressure? And say, it's a low blood pressure, say diastolic is around 66 or something. We very often see them actually in 110 and 60. So there's nothing wrong with them, of course.
No, that's a very interesting observation. Majority patient, all of us will agree, they do not fear the high level. They always they are afraid of the lower level. They are always concerned about my BP is falling down and down. So what will happen? And as you said, I am suffering from low blood pressure. Actually, it's very difficult to convince them. There is nothing like no diagnosis that patient has a low blood pressure. But what Harrison suggests, if the blood pressure drops by 30 millimeter mercury from his initial level, that is relative.
I think this question has been going on for a very long time. I remember there is I don't know whether you remember it. Manav will probably remember it. There's a journal called Practitioner. In our time, there's a journal called Practitioner, and one question was asked about one question to the editor. If somebody comes to you in the West, it's a German patient asking a German doctor, what do I do if I see a patient who has got a low blood pressure? He said, rule out all the secondary causes like bleeding or whatever, endocrine causes or whatever it is. And if you don't find anything, just congratulate the patient. He's going to live longer than the person who has got a high blood pressure. So that's a common scenario in our time. You don't find them in the books.
Most tell দিব কম হয় মোটর পেশেন্ট আহিলে most tell দি দিব আৰু একো যদি নাই but right Deepak is right, but before saying that tell দিব তাৰ আগতে you have to rule out the other causes.
Anup is smiling quietly. Nephrologist is smiling quietly. He probably doesn't see a low blood pressure at all. He sees the blood pressure which you cannot, control. So, this is a resistant hypertension. We'll come to that a little later. But I know in these guidelines, beta blocker has been brought forward as a. Do you think that's a good thing? For India, I mean. For India, do you think it's relevant?
Yeah, I think it is relevant. In fact, I have been using beta blocker, even atenolol. Nowadays, hardly anybody uses atenolol. But it's a very good drug. Good drug means, to my mind, it is a very cheap, easily available, long-acting. Atenolol is a very good drug. Atenolol has been thrown out after ALHA trial, considering that it may not reduce the stroke. But now that data has come, all beta blocker reduces stroke. So, beta blocker is good.
So, I think we were much ahead of the Europeans because we had been continuing with beta blocker for a very long time. We never actually discontinued it, and we have graduated from non-specific beta blockers to now very specific beta blockers or selective beta blockers. So, I think in a way, only problem with us that we do not document them in our cities or studies. I think the young generation should be stimulated to do that. So, I think any questions so far or comment? Noni, you can't ask. You can just jot it down. Jot it down, and you can please jot it down. I'll answer your, put it to this panel because otherwise we'll overshoot the time. Please give a sheet to Noni also. I got it, Mamu. So I'd like to involve all of you actually. Some interesting questions have come up. Always check for your postural hypertension in people with hypertension. One type of diabetes, symptoms of postural hypertension or this thing. I think of course, postural hypertension is an important situation we need to address, and particularly in the elderly. So, well taken, the point is one taken. I think Dr. Sangeet Datta has said, best treatment for hypertension in cirrhosis of liver with edema. The question is, what is the best treatment for hypertension in cirrhosis of liver with edema? Any comments from you?
Before that, actually, I want to make one comment regarding the postural hypertension measurement. Actually, when we measure blood pressure, that part probably we did not discuss, the basic part. Though we write in theory examination, even answer in the Viva also, probably majority people are not doing justice to the patient. The way the blood pressure should be measured. So majority guidelines, in fact, all guidelines they suggest it should be a sitting position. And the patient arm should be at the level of his heart and should be totally relaxed. and all those precautions, plus the blood pressure cuff itself. Because in India now, the obesity is increasing. So if you apply a standard cuff for an obese person, blood pressure will be spuriously high. And plus the timing. The majority guideline they are suggesting the blood pressure should be measured by an automated machine, because the machine will not make any lie. But if the person measures it, there is always a chance it will be biased. Again, the measurement also should be taken a 1 minute interval, at least 2 or 3. And the average of 3 should be given, and that should be taken as a blood pressure that is in the office. If somebody takes in the, and of course both the arms should be selected, and one standing. In case to detect postural hypertension in the very beginning, particularly in elderly individuals, frail patient, and diabetics, and patients suspected with suffering from autonomic neuropathy. So these are actually blood pressure measurement itself is a long process. In the OPD, in majority busy OPDs, blood pressure is always measured by sometimes even by technician. As you grow up our ladder of our hierarchy, we just tend to neglect it or to delegate it to a person who does not have any knowledge. Even in our hospitals, I have seen BP is measured by the sisters. Many times they will measure over the
Dibba, I think if I interrupt you again, what is the worst and what is the most, what should I say? If you go to a hospital, what is the most neglected piece of equipment in a hospital? Is it hypertension BP machine? Has it ever been calibrated? Has been cuffed, be properly looked after? Is the tubing checked? So we talk hi-fi things about hypertension. These are the basic things we always forget. So if you get a bad reading, if you don't get an inadequate reading, what's the point of treating the reading? You want to treat the patient with a proper reading. Anyway, so that is one thing. But one interesting thing the ESC guidelines have said, you have to validate your blood pressure machines. But interesting thing they have noted that the Android BP machines and all, you need to validate. Interestingly, the electronic machines do not need to be validated. Once it is validated once, you don't need to validate again. So when you buy it, hopefully it is validated, so you don't need to, validate it again. So only thing is that look at the cuff and the tubings and the stuff. But the other machines should be validated.
Regarding the electronic machine, there is worldwide it has been seen only 17% of those machines are validated. Whereas 83 are not validated, even in US. So they have given some guidelines, American Heart Association.
Yeah, there are some actually validating agencies, but I don't know whether it's in India, particularly in Assam, as far as I know, there is none. So what do we do with your machine? That is the thing. What do we do our machine? I think the mercury machines are being phased out now. So what do we do about this thing? It's a big, big question. I don't know how to answer that. If anybody has got an answer, we'll be very happy to have them and know it.
What is the difference between the the office blood pressure and your home or ambulatory blood pressure measurement? Which data you will consider for treatment purpose?
There is an interesting observation, because it was seen whatever data has been collected was collected only office reading. So all guidelines, all trials, they have measured the office reading on the basis of which they have calculated all these prognostic markers.
I think, but we have digressed from Sangeet's question. What is the best treatment for hypertension? He has phrased it very nicely. He hasn't said which is the best molecule. He says what is the best treatment? Maybe a combination of drugs with hypertension, cirrhosis, in liver.
Beta blocker?
Yeah, I think several things. Beta blocker and spironolactone.
He has got cirrhosis. He has got expected to have portal hypertension. So beta blocker.
Beta blocker definitely.
Songiti to the I can't answer to this.
No, he will use loop diuretic.
And of course, spironolactone is another drug which is very good in reducing blood pressure, particularly in resistant hypertension. If he's got a lot of edema, then we can also add a loop diuretic with that. So with this, and otherwise you can choose any other antihypertensive, you can use it. I think, amlodipine or whatever. There's another question. Is there any specific guidelines for high altitude area for hypertension?
Deepak, there is a question from the, please.
Hypertensive, but I have read an article where AC inhibitors are indicated because there is a RAS system also in the cirrhotic patient. I think that should be taken into account.
Yeah, of course. But interestingly, you know, in the olden times, we used to use, you know, non-specific beta blockers like Indira. What is the role of specific, now then more selective beta blockers in the case of portal hypertension? What's your take, Sangir, about it? Do you prefer a selective beta blocker or a non-selective? Fine. Okay. So that's carvedilol is a highly selective beta blocker. So we should use carvedilol that's a choice.
Yes.
That's a beta blocker of choice.
Yes. And Anup says, telmisartan has shown to be beneficial in portal hypertension and the hemodynamic circulation within the liver. So should you think that we should use telmisartan? If a patient is usually cirrhotic patients are hypertensive because of vasodilatation. But still they have hypertension because of comorbidity, diabetes, obesity. So what should be the first choice? Should it be telmisartan? What did you say?
See, in specific situations, specific drugs will be there. Like CKD in the, our renal symposium, it has been said that CKD, if you use S inhibitor or ARB, it delays the progression of CKD. But what is the essence of all guidelines, be it European Society or any guidelines? It is the reduction of blood pressure which determines the outcome rather than the actual molecule which it is a split of hairs actually that determines the difference between drugs. So whichever drug is more tolerable to that very person, feasible to that very person, manageable to that very person, our target should be reduction of the blood pressure.
Okay,
There's another question.
Just can I one comment, just very small comment on this AC inhibitors in such patients. Because in cirrhotic patients, there may be a third space loss, severe. So there may be severe intravascular volume contraction. And in such condition, probably AC inhibitors are not a good choice, right? AC inhibitors are not a good choice when there is a severe volume contraction, intravascular volume contraction. In cirrhotic patient, there may be, because of ascites, there may be sometime in third space loss, we call. Again, then regarding the beta blocker, again, we are very fond of beta blocker because even then JNC 5-6 also, they tell us beta blocker is not a fast of the drug, which means for nephrology, there is no other option because our basket of antihypertension is such a high, we have to use 3-4 drugs. So unless you use the beta blocker, there is no other option. So we have to use the beta blocker from the very beginning, although it is in combination with the other drugs. Secondly, about the beta blocker, where Hemda told me about the atenolol, there's all the conventional beta blockers, they used to be very dyslipidemic drugs. So that was one of the reasons why it was discouraged in the beginning, because it's a dyslipidemic, it can cause and again cardiovascular, it can enhance the cardiovascular morbidity or mortality. Probably better to omit it. And that way also that the other selective beta blocker has come. Probably that is a nice concept. Then selective beta blockers can be used so that it is never in dyslipidemic drugs.
Correct.
If I am not correct, please.
Yeah, you are correct. You are very correct. But only one thing I wanted to ask you. When you say we Indian nephrologists or we nephrologists as a whole?
As a whole.
I mean, we in India particularly, yeah? Yeah, that's why I'm saying, India, we have never gone out of using beta blockers. Nani, please, you wanted to ask something.
No, I just like to add a comment on beta blocker. Sorry, I fully agree with the Kalita sir. We should be disease specific. What is the cause? The things are causing the hypertension that should be treated. Regarding the beta blocker with the CLD patient, one thing we should remember that because already CLD patient is low hypertension, third space fluid is more. If you give a beta blocker which reduces BP more, that will be catastrophe. That should not be used in the CLD patient. The propranolol is a good, other indications, portal hypertension is good, but is not a very good antihypertensive drug. Similarly, carvedilol is not a very strong antihypertensive arrangement. Moreover, even while using the other beta blockers, recently in the API group there is some discussion IAT has put up that carvedilol should not be used in severe liver disease. And also the severe portal hypertension, it should not be used. Whether it has got a beneficial effect on the fast bleed in the portal hypertension patient. So few things, these are the whole prescribing beta blockers, really these few points to be taken care of. And regarding the, as a beta blocker, as a first line anti-HCV drug, the Indian guidelines, the other, in Indian context of the patient, the Indian people are more like sympatho, they are more, the sympathetic action is more, and the younger people who have the heart rate of more than 100, I think that these are the subset of people, they should be advocated for the beta blocker.
Thank you, got your message. I think, can we have the first consensus then? In a case which Sangeet has put forward, we'll use a RAS inhibition like, telmisartan. We'll use a beta blocker like carvedilol with, reasonable doses, as well as I think we should use a spironolactone. There's another drug, particularly this patient has got edema, and if the edema is refractory, we can use a loop diuretic. So that is the first consensus we have arrived today in this house. I think please give a hand to Sangeet, please. Thank you for raising it. Another interesting question has been raised here by Dr. Nitin. Is a Lieutenant Colonel. Dr. Nitin is here somewhere. Yeah, Dr. Nitin, you must be with the army, are you? And served in the high altitude and probably had the high altitude hypoxia or whatever. And it reminds me of Dr. Sujoy B. Roy, who actually discovered cardiology from All India Institute. He is no more. He actually coined the term high altitude hypoxia in India. So is there any specific guideline for high altitude area for hypertension? I'm not. But I think, do you have any answer to that, Dr. Nitin? In the army, do you have anything like that?
So, with our likewise, many serving soldiers, we go there, and after 1 month or 2 months, they start having a hypertension, sir. And when they are descended to a lower altitude, the BP settles down. But we see the residual effect after 2 months, 2 to 3 months. They tend to get hypertensive in subsequent way. So I wanted to know whether we have to take the follow-up of this patient in future, or to leave it like to de-induct from the high altitude.
Now, was it generalized or for particular people?
How many patients? How many?
Many patients are likewise. If
many patients mean what is the percentage of the patients?
So likewise, 100 troops, 100 serving soldiers go there in the high altitude, and 30 to 40% end up with a hypertension. And we label them as a high altitude related hypertension. And then we de-induct them from high altitude.
Now, that is an interesting observation, because there was a study from Spain. They followed up people for 15 years, 1997 to 2017. And they were young people. They were supposed to voluntarily declare their health status, where they have migrated, what disease and all that. After this 25 years follow-up, it is seen the people who have migrated to high altitude areas, their blood pressure and other non-communicable disease-related risks, everything has come down. So that's why there was a question, even if you go to the Himalaya and pray there, maybe you live more than 100 years.
Longer. You live
so
long.
this observation, this is quite an interesting observation. I do not know.
Problem coming to Guwahati Medical College also. High altitude hypertension. And the army says that if there is a data saying that high altitude he has hypertension, comes down for 6 weeks. 6 weeks high altitude, 6 weeks baseline. And there's high altitude, he has to have a certificate saying that he cannot work in high altitude. But I do not know the percentage. But there is a circular saying that high altitude hypertension, they bars a army person to work in the high altitude.
Is it a persistent hypertension or
yes.
I think that will be a good observation and carry on some study, because it will be all speculation. At best, it may be the high altitude hypoxia which has increased the sympathetic tone, and that has caused the hypertension.
So
but that would be a good idea.
That is actually established. There is an AHA study already that the high altitude causes. There is a sympathetic increase, surge, and that causes. Even carbonic anhydrase inhibitors are used. Probably, sir, would yes, I think so. And if it is very bad, dexamethasone is also used. Probably nifedipine, probably.
Carbonic anhydrase axon is very temporary. It will not remain for.
But this is for the acute cases.
Yeah. And
because they have no dexamethasone.
Even the sympathetic overactivity will not explain the persistent hypertension in that patient, because in case even in chronic kidney disease where we use erythropoietin, that also causes hypertension. In
Yes.
hypoxia, that increases the erythropoietin level. That
That is already established, yes.
I think we should go to the other part. That
Yes.
is a special
next
part
question.
which
I think, this
probably
is an
has
interesting
opened our eyes
topic
to
which
go for a
needs to be
study.
resolved. I think, probably Army and the armed forces are very well versed with that condition. And if you, have anything, please let us know. We'd like to know as well. So the next question is about nocturnal hypertension. How to address the nocturnal hypertension and morning dip situation. Nocturnal hypertension. Yeah, I think, if somebody doesn't have a morning dip, nocturnal dip, so how do you address that situation? It's an interesting question. These are the people who are the diabetics, basically. Diabetics have this, feature of non-dippers, and there also the early morning surge is more. The one way of addressing it is probably, this is not given in the guideline, they said you give at the night time, you give a RAS inhibitor. Like, certain, one of the certains at night, if you give, it addresses the issue. But I think as a whole, probably if we take the tablet at night, this probably will address the issue to some extent. But otherwise, you have to issue the basic issue of hypertension, the diabetes as well. I think Sanjeev Kakoti, once I remember, is in Jorhat. The question was raised to him. He doesn't remember it because I remember it now. Somebody asked, what happens, when should you take the tablet, daytime or nighttime? His answer was quite practical. If you're a late sleeper, if you go to bed late, take the tablet at night. If you're an early sleeper, take the tablet in the morning. Probably that's a very practical scenario.
We do have trials on this. This is called chronotherapy. Should you have in the morning or at night? In fact, there is a very large trial from Spain called HYGEA trial.
A lot of trials actually.
Yeah,
from Spain.
HYGEA trial, which has tempted this very idea we should give the drug at night because of these non-dippers and morning surge BP considering. And in that very trial, it has been shown because their monitoring was 24 hours BP monitoring, 48 hours, 24 hours BP monitoring. And they have shown that if you give at night time, you can in fact prevent the events also. But subsequently, it has been refuted by many other trials. And interestingly, we are very much interested to know about 24 hours BP monitoring. It gives a lot of data, but most unfortunate thing is non-reproducibility. You get it done today, get it in the same person without any intervention. After 1 week, you cannot reproduce it. That's why European Society has frankly said that you go for monitoring on office BP monitoring. Home BP monitoring and 24 hours BP only in special situations. Because all the outcome trials are based on office BP monitoring.
So anyway, the Spaniards are obsessed with sleep anyway. Whatever they do, they have a siesta in the afternoon, so their sleeping pattern probably doesn't, comply with us. Sorry. Sorry.
When you talk of nocturnal hypertension, what is the level of the BP beyond which you can consider the patient is having nocturnal hypertension?
Well, hypertension
It should be less than 110/70, or otherwise normal dippers is 15% less than the daytime. And if it is less than 10%, it is non-dippers. And non-dippers is mainly related to kidney disease and chronic kidney disease progression.
Normally this is usual procedure, the BP drops down to below 120/70.
So less than 100/70 is
my question
acceptable.
is that if patient has having some sort of nocturnal hypertension, how to detect that?
ABPM is the answer. But question is that is not reproducible.
Commonly,
So
can
that's
you
why-
ask our patient to take the BP at the night time also? Yeah.
So if he wakes up, then automatically his sympathetic drive will be more. So that may not be our actual nocturnal blood pressure.
It is not reproducible, no, that is the point.
There are
If you
some
measure
interesting features in, 24 hours BP monitoring. We are very much worried non-dippers. We are very much worried nocturnal hypertension,
reverse dippers, yeah.
And there is another called hyper dippers, more than 20%.
Super dippers.
And they also have got high cardiovascular mortality. So we are yet to learn many things from.
It's really a miracle that we are still alive with all these conditions. Anyway, so I think we're running short of time. I think we can carry out with this discussion forever, I think. So hypertension. So we have learned a few things today. Chairpersons, if you have any words of wisdom, please let us have that.
No, my voice is very bad. I'm very sorry. But even then, it was a very excellent discussion. Few of the very important points have come up. One is the, this office BP blood measurement. It is very, very important. And in the new guideline, already yes, told, the beta blockers have come in the first line of treatment, like your CCB, AC inhibitors, then diuretics, and your CCB, calcium channel blockers. And another important thing is that the risk factors he has mentioned, like your sleep apnea, then NAS, then chronic inflammatory diseases, they are able to come up in the causation of hypertension. So even the ESH, they have recommended the these newer modalities of treatment and this artificial intelligence for the this monitoring of the blood pressure. So with this, we should come.
I'll have some comments finally.
Yeah, Kolita, please.
Yeah. We should be convinced that all drugs are good, be it the cheapest one, be it the costliest one. What is more important is compliance, because somebody is known to be hypertensive. To maintain his blood pressure, the compliance is the commonest cause of resistant hypertension is non-compliance, and commonest cause of non-compliance is high price. So choose the drug, cheapest one, easily available one, and patient can buy easily. That will give the compliance and that will control the blood pressure.
Pseudo-resistant hypertension should be ruled out first.
Uttam, we can answer this. I think that's from Professor Ali. Important question to you, particularly. He said, ask Dr. Uttam Nath about this one. Haven't you? Yes. So what is the lowest level of BP that calls for a drug that would raise the BP for subjective and objective features? Do you want to give a drug? If somebody's BP goes very low, do you want to give a medicine to raise the BP? Is there anything like that? In old times, we had Micor and Coramin. When people was about to die, we always used to give. That never worked though. Anyway, so now?
So this question probably already, the low BP, regarding low BP, already answer been given. There's no such question of low BP. But so to satisfy the patient, we need to give him what we have been found in clinical practice, low BP, what to do. So I have already said we have to rule out the other causes, secondary causes. We have to rule out the cardiac causes of low BP. But to satisfy them, at least we should give some ORS and IV fluid. That is my personal experience. And some salt can be given.
Evidence of low BP, certain objective evidence, low BP, objective evidence.
Yeah, actually what I feel, sir, the context will define the treatment.
No, my question is not complete.
Yes, sir.
Please get my question. It is a very basic question I am posing. Low BP, everybody is saying, we are telling that there is no BP, no low BP entity. There is no low BP entity. That's how we escape. We try to escape. But the patient has even symptom of low BP.
His question is, if somebody is symptomatic with low BP, how do you approach it?
Yeah.
He is on medication or not on medication?
No. Like that you go for...
But he's symptomatic. He's symptomatic.
He's symptomatic.
He's symptomatic at night.
He has got some evidence of low BP.
Sir, is he a case of SIAD, inappropriate idiot secretion?
First thing, sir, we have to stop the medicine.
That is yet to be inquired.
Then assess the cause.
That is yet to be inquired.
No, he said dizziness and all. Maybe.
So he may have giddiness, he may have drowsiness, and he may have...
Yes.
Oliguria.
Is it?
Oliguria.
Sir, first
I think,
you have to rule
I
out
think
the
we should close the session, no?
Sir, one thing, sir.
There is a request from the organizers to stop the
Chairperson,
session, please.
this is beyond my control.
Sir, we underdiagnose one with low BP with POTS, sir. We underdiagnose POTS because low BP, 15 to 50 years, female, especially females, they say when I get up, after some time, I feel a bit dizzy.
So
we don't get anything.
We have to rule out the underlying etiology and first give
we
symptomatic
underdiagnose
treatment
POTS.
shots.
That's
Yes.
what I'm saying. We underdiagnose diseases like POTS because it is common, yet we do not diagnose. That is one of the things that I want to share.
There's postural hypertension. Anyway, so I think I love hypertension, not as disease, but discussion. Okay, I really love it. So everybody has a comment on it. Every has got an opinion on it. But our opinion and comments should be evidence-based and experience-based. Thank you very much. Thank you very much. All
Thank
my
you, friends.
panelists.
We have witnessed
Thank you
a
all.
masterly session given by some experts on their own field. Give them big hints. And we will conclude this session here as we are constant of time here.
After a very energetic and very infectious panel discussion, we would like to move ahead with our academic session.
A request not to leave the seats. The tea will be served in the seat side, because there will be a chairperson's oration now. So we would like to request you to please stay inside the hall.
Now that things have settled down a bit, we would like to go ahead with the academic session. We have the chairperson's oration next. I would first like to call upon our chairpersons for the session, Dr. Narayan Upadhyay sir, Dr. Kamaleshwar Neog sir, Dr. M.K. Goswami sir, Dr. Kamal Nahata sir, and Dr. Mahendra Keshan sir. I would like to repeat, to chair this session, I would like to request Dr. Narayan Upadhyay sir, Dr. Kamaleshwar Neog sir, Dr. M.K. Goswami sir, Dr. Kamal Nahata sir, and Dr. Mahendra Keshan sir to kindly come to the podium and take their seats.
We would now like to felicitate our chairpersons. We'd now like to invite to stage our respected chairperson API Assam State Chapter, Dr. Arunima Goswami Vaido, please to come up on the stage. We'd now like to felicitate her. Dr. Deepti Rekha Borua will felicitate Vaido with her salang. I request Dr. Kishore Chakraborty to please felicitate ma'am with her horai. I request Dr. Srikriti Adhikari to felicitate ma'am with a flower bouquet. I'd now like to request Dr. Ankumani Borua and Dr. Atanu Saha to felicitate ma'am with her japi. I request the others also to please. Thank you so much. We now have a citation to present to ma'am. I'd like to request Dr. Dijen Das to read out the citation. So, my mistake. I'd like to request Dr. Pritam Barthakur to kindly read out the oration, the citation.
Today, I really feel very happy because myself and Dr. Amoldev Goswami is here. We first thought about making Vaido the chairperson of API Assam chapter, and with all your support, we proposed the name of Vaido, and today I really feel very happy to read this citation because Vaido is there to present the chairperson's oration. Association of Physicians of India, Assam State Branch is honored to express its sincere gratitude and great appreciation to Dr. Arunima Goswami, Chairperson API Assam Chapter, for her immense contribution as an astute clinician, for her keen interest in academics, and for her exceptional organizational skills. Madam, you are currently spearheading two apex professional organizations as Chairperson API Assam Chapter and President IMA Assam State Branch with extraordinary capabilities. You have passed MBBS from Guwahati Medical College in 1976, securing the 4th position, and MD General Medicine in 1981. You also did a short course in Introduction to Diabetes Care from Newcastle University, Australia, and secured 1st position out of all centers in India. You have been awarded with Fellowship of IMA, Academy of Medical Specialists, and Indian College of Physicians. You have contributed immensely to the field of medicine in terms of excellent patient care, dedicated and selfless service for mass awareness, as well as in the field of rural services. You have been encouraging the younger generation to work with dignity and sincerity. You have published many articles, also edited API Update and IMA Calling, apart from remaining the editor of Name Care Journal and newsletter for a long time. You have also participated as faculty in numerous scientific conferences in the country. You have been bestowed with IMA Assam State Branch President's Appreciation Award in the year 2009, and IMA President's Appreciation Award for Best Adjust President of a State Branch in 2022-23. API Assam chapter is extremely pleased to have you as the speaker for this prestigious chairperson's oration today, that is 16th of December 2023, on the occasion of API Conference Assam held at Tezpur. Accept our sincere gratefulness and applause for your sincere work and dedicated service to the ailing populations and to the medical fraternity. May we wish you good health, long life, and may you continue to guide us always. On behalf of API Assam Chapter, Organizing Secretary Dr. Dijen Das, Organizing Chairperson Dr. Otul Chandra Soikia.
Thank you so much. I would now like to hand over to the chairpersons.
It's an honor for all of us as chairpersons to witness the oration, prestigious oration on the topic of essence of a physician by Dr. Arunima Goswami. I call upon her to go ahead with the oration. Thank you.
Thank you so much. I'm really touched by the honor bestowed upon me, and I am feeling privileged and honored to stand here and deliver this oration. Respected chairpersons, honorable esteemed members in this audience, postgraduate students, ladies and gentlemen. Today my subject of oration is Essence of a Physician. This subject is very close to my heart. I feel that now in the different change of the fabric of our society, the physicians, they have become more mechanical, less empathetic, and they are more after money. So in this changed scenario, I feel that we must go back to the old school to understand what is the essence of a physician. And this is an abstract subject, so I will go through several slides where I will give a gist of what actually is the essence. And it is not just one simple line, it is a lot of things put together. First of all, I dedicate this oration to my late father, Dr. Anandeswar Borthakur, who was a great physician. I learned a lot from him. He used to say that the patient is the best textbook. Ketiao patient bhoy nokoribi, patient sabi, patient or prato hikibo paribi. He was a Calcutta Medical College alumnus, a clinician par excellence, and he was the first API member of Undivided Assam. Of course, then the Assam chapter of API was not formed, so he was a direct member from the center. Now, to understand the essence of medicine, we must also understand the evolution of medicine over the years. Illness and injury are all as old as mankind. Some form of medical treatment evolved from the Stone Age itself. As communication was rudimentary at that point of time, the evolution of medicine developed in different regions of the globe in different manners and at different paces. Primitive men indulged in a lot of bizarre, often barbaric practices of healing, from letting blood flow out of the body and cracking the skulls open. Man has come a long way in the evolution of medicine. The essence of a physician entails knowing these history of medicine, as it not only gives us a sense of accomplishment by the achievements of our brethren over the centuries, but it also paves the way for our own thinking of future developments of medicine. These are the barbaric methods which were used then, but we have come a long way. And medicine evolved, as I have said, in different regions of the world in different forms. But I want to mention here about Imhotep. Imhotep was a vizier, that is a minister of a pharaoh, in 2900 BC. And he is the recorded oldest physician of the world. Then there was Chinese medicine, Indian medicine, Greco-Roman medicine, Dark Ages, where the Satan was the ruler, the Christ. Christ actually saw that, the church saw that there was no development. People used to believe in the church and not go for their own potions and treatment. And then there was a medieval European medicine and the Renaissance. This is our own system of medicine, Acharya Sushruta, 800 BC to 700 BC. He developed different forms of surgery, and the rhinoplasty method is used even now, and he is regarded as a father of modern surgery. Acharya Saraka, he was from 4th century BC to 3rd century BC. He was a physician, and he treated many diseases, more than 200 diseases, with many potions. Then this is Hippocrates from 460 BC to 377 BC. He was famous for the Hippocrates Oath, which was the first ethical-based document regarding the treatment of diseases by doctors. He treated many diseases and is considered the father of modern medicine. Following the Renaissance, modern medicine developed at a very rapid speed. There was circulation of the blood, vaccination, discovery of anesthesia, germ theory of disease, antiseptics, antibiotics, diagnostic technology, everything, transplantation technology, and whatnot. So modern medicine arrived, and that is now practiced in this world. And most important of all, evidence-based medicine was the norm of our time. Now, what is the essence of a physician? If the evolution of concept, I'm gradually bringing it. The role of a physician is fundamental to human society and culture. The heart of medicine is a direct transaction between a doctor and a patient. In that transaction, the one essential thing to be given to the patient is attention. The power of attention is the power to listen, which we don't have time, to be present, to allow all the sources of perception within us to make out towards another human being. The power to be silent when necessary, to allow thoughts to combine creatively as a real power of the mind. The development of the power to listen to the patient and to oneself is the essence of a physician. It is also the essence of life. Nowadays, we don't have time. We don't have time to hear to the patients. We don't have time to listen to our parents. So it's all very rush. So becoming a physician has meanings far beyond completing medical colleges as in residency. It is the entry into a new and unique way of life. I remember that when I entered medical college as a student, ragging was present there. And they asked me, why have you come here? Then I said, idealistic, that I want to serve patients. So that sort of thing was then. But now if you ask a medical student, the answer will be different. It would be to make money. The most important point is to have an inner calling to become a physician. It is a calling which one is bound to either live it or leave it. So if you don't have the inner calling, you can never be a good doctor. Basic sciences are the pillars of major clinical advances in medicine. The scientific infrastructures that we appreciate today is also the springboard for development of medicine in the future. We are indeed in the age of molecular, biological, genetic, physiological medicine. The medicine which we practice today is more than that intuition and common sense which we used to practice before. It is precision-based and evidence-based. Explosion in medical knowledge has led to increasing specialization and super-specialization in medicine. The same fundamental molecular and genetic mechanisms are applicable to all systems of medicine. In this background, every physician must delight. It should be a passion, it should be an enjoyment in learning the new, correcting the old, and perfecting the future. The physician should also be an academician. The modern physician has to remain updated in respect to the new developments in the medical world. What is true today may not hold good tomorrow. Therefore, the modern day physician has to have access to journals, new books. They have to attend conferences and CMEs and engage in research. Presenting papers is also helpful because the best way to learn is to teach. To become a teacher also is the best attribute of an academician. The patient as a clinician, because the patient-physician interaction entails clinical reasoning and decision-making. This begins with elucidation of complaints, followed by inquiries to address these complaints in precise ways. The process includes history-taking, physical examination, ordering diagnostic tests, integration of clinical findings with test results, and arriving at a diagnosis. This is followed by understanding the risks and benefits of the possible courses of treatment. Nowadays, we give the options to the patients and consultation with the family and patient and family members to develop future plans. Physicians have a growing literature of evidence-based medicine to guide this process so that maximum benefit is realized, though of course there may be individual variations in different patients. Again, the physician has to be a caregiver also. Being both professional and caring is an acquired skill. A physician can diagnose and prescribe in a correct and scientific, but at the same time insensitive way. We come across many doctors who are insensitive. The patient may become better, even cured, but still remain unsatisfied. The patient may think, does my physician really care? Does what happens to me really matter for the physician? Patients want and deserve compassion and understanding. Patients also expect to be kept informed while receiving professional service. Easy, supportive interaction with patients is a skill that comes readily for some and with great difficulty for others. Nevertheless, this skill has to be acquired. You give but little when you give of your possessions. It is when you give of yourself that you truly give, was said by Khalil Gibran. We have to give ourselves. Only then we'll be able to achieve to become a great doctor. This giving of oneself with ease, with grace, and with meaning is for most persons an acquired skill. Sometimes a deep sense of awakening is required to develop this innate sensitivity. These traits remain imperative to become a complete physician. Again, a physician has to be a professional, and this professionalism attributes a commitment to excellence, a commitment to the interests and welfare of patients, a commitment to the health needs of the society. True professionalism aspires to altruism, accountability, duty, service, honor, integrity, and respect for others. Clinical ethics, this is also important. Clinical ethics is a practical discipline that contributes to improvement in patient care. It focuses on patients' preferences and choices. It highlights moral obligations of physicians like honesty, competence, compassion, and respect. Ethics teaches physicians about informed consent, truth-telling, end-of-life decisions, advanced directives, cost containments, and healthcare reforms. Now the concept takes, evolution was there, now the concept of the essence of a physician takes place. Although many good doctors are well trained in the basic and clinical sciences, many great doctors hold that other habits are equally if not more, crucial. When I call knowledge, it's not only knowledge. There are many other things which are required. To cure sometimes, to relieve often, to comfort always. That is what Edward Livingston Trudeau, who was a founder of the sanatorium treatment for tuberculosis in America. Investigative work and deduction, of course, we require. When you have eliminated the impossible, whatever remains, however improbable, must be the truth. This is in the case of rare diagnosis. Then we have to take care of our own mental and physical health. John F. Kennedy, he said that intelligence and skill can only function at the peak of their capacity when the body is healthy and strong. We will have to develop the art of listening, the master listener. Sir William Osler said, listen to your patient. He is telling you the diagnosis. We have to listen. Homoye nai, kole sarok dekhwalu, kintu eku bane besi kotha napatile. It should not be like that. Learning to love one's own work, that is also important. Your work is going to fill a large part of your life. And the only way to be truly satisfied is to do what you believe is great work. And the only way to do great work is to love what you do. This was said by none other than Steve Jobs. We have to treat the patient holistically. A good physician treats the disease. The great physician treats the patient who has the disease, was said by Sir William Osler. Empathy. Empathy is very important. We are losing that empathy. People will forget what you said. People will forget what you did, but they will never forget how you made them feel. This was said by Maya Angelou, who is an American black activist. We have to give attention to detail. It's attention to detail that makes the difference between average and stunning. To this I have added, trifles make perfection, but perfection is no trifle. So we have to be resilient. It's not the strongest of the species that survive, nor the most intelligent, but the ones most resilient and responsive to change, was said by Charles Darwin. And being resilient is what I believe everyone in this hall will be able to relate with, because we doctors go through a lot of ups and downs. A lot of patients, they improve, then they deteriorate, and a lot of happenings occur. We are not satisfied always. We have to move forward, so we have to be resilient. We have to take responsibility. I am not a product of my circumstances. I am a product of my decisions. And also, it is very important to practice altruism. It is not always money, money, money. When you truly follow your passion as a physician, then money and fame will be a byproduct of your efforts. But if you chase the money and fame in the first place, then the true joy of being a doctor will elude you. Another thing, another problem which is looming is artificial intelligence. A lot of work is being done by the AI, like the pulse, we don't have to see, we put the pulse oximeter. So there will another lot of things are coming in. And the concept has come that are we actually entering the post-physician era? Does the role of a physician now remain as a scientific technician only? Is the compassion and the human attention which was once given by the physician replaced by a nurse practitioner, social worker, or counselor? Will artificial intelligence ultimately replace the academic and the clinical work of the physician? The machine will definitely rise. And this is the machine with a stethoscope. Will it have the tender touch in this digital era, which is the theme of this conference? The answer to these previous questions is difficult, but to rediscover the meaning of the physician of today, we will require to know with certainty their sense of being a physician. The role of a physician is fundamental to human society and culture. And in one mode or the other, this role always exists from time immemorial. So ultimately, what is the essence of a physician? The essence of a physician means blending within the human psyche of knowledge and love, the mysterious but necessary balance between the mind and the heart, scientific detachment, and at the same time compassionate engagement in the suffering of our fellow human beings. The constraints of today's society has no intrinsic power to prevent the physician from disappearing from the face of the earth in the present social fabric and are moving into a post-physician era of artificial intelligence. The essence of a physician is a conglomeration of all these attributes which we have already discussed. It is a nectar of all the qualities of a physician, like being a scientist, being an academician, a clinician, a caregiver, a professional, an ethical person, being a medical detective, a master listener, a perfectionist, a responsible and a passionate person, having an altruistic attitude, and all this with the wisdom of generations of medical men from the prehistoric times to the modern day. As Sir Robert Hutchinson said, this is from the Love and Bailey, from inability to live well alone, from too much zeal for what is new, and contempt for what is old, from putting knowledge before wisdom, science before art, cleverness before common sense, from treating patients as cases, and from making the cure of a disease more grievous than its endurance. Good Lord, deliver us. Sir Robert Louis Stevenson in 1800 wrote this eulogy to the doctor, meaning the physician. There are different men. There are men and classes of men that stand above the common herd. The soldier, the sailor, the shepherd, not infrequently the artist, rarelier still the clergyman, the physician almost as a rule. He is the flower of our civilization, and when that stage of man is done with, only to be marveled at in history, he will be thought to have shared but little in the defects of the period, and to have most notably exhibited the virtues of the race. Generosity he has, such as is possible only to those who practice an art, and never to those who drive a trade. Dissection, tested by 100 secrets, tact, tried in 1,000 embarrassments, and what are more important, Herculean cheerfulness and courage. So it is that he brings air and cheer into the sick room, and often enough, though not so often as he desires, brings healing. Finally, na tu aham kamoye rajayam na swarga na punarbhavam kamoye dukhataptanam praninam artinashanam, meaning, I do not for a royal realm aspire, for release or for paradise, to serve those bent with grief I desire, and calm their sorrows and help them rise. Precisely, this is the essence of medicine, condensed by our forefathers in the scriptures into one simple line. This is a bibliography, and thank you for giving a patient hearing.
Ovation. I think this was an excellent talk I ever heard, with your compassion, love, devotion, everything combined. We all thank you. Let us join to thank you and say you are great. I hand over the mic to my co-chair, Dr. Kamalesh.
Thank you, Madam, for reminding us of our duties from the history. Thank you very much.
We really feel privileged to chair this session. This lecture is an eye-opener, where we stand, irrespective of who we are. Really, it is a masterpiece. So I would again like to salute you, Madam.
Thank you for giving me this opportunity
So-
and this honor.
This session is over. Thank you.
Thank you, chairpersons. Respected chairperson, ma'am, may I please invite you on stage for a group photograph? And I'd like to request everyone, as much as the stage can accommodate, to please come up and have this photograph with madam. हाँ हाँ वो किसको किसको करेगा वो लिस्ट था ना डिजेंडा के पास ही होगा सर हो सर हो सर सर sir please come up on stage sir Goswami sir you are required on stage आजा 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 हम लोग यहीं रहते हैं पीछे अरे होगा होगा आसू सर
থাকা জায়গাতে যাব